A very good morning to all of you and welcome to the paper presentation for the TMC-DAC 2021. I'm Dr. Gauri Gangakhidkar and I would like to take this opportunity to welcome our esteemed judges for this event. First, we have Dr. Charu Deshpande, who is the professor and head of department at the BYL Nair and TNMC Hospital. Welcome, Charu ma'am.
Morning.
Good morning, ma'am. Next, we have our very own Dr. Kedu, who is now the HOD at the D.Y. Patil Hospital, Navi Mumbai. Good morning, sir. Welcome to the paper presentation. Since we're all here, I think we can start with the paper presentation. The videos have been sent to us before. The videos have been recorded for 4 minutes, and we have 2-minute time for discussion at the end of every paper. We start with the videos, Manas.
Yeah, wishing every contestant all the best.
Yes, ma'am. We can go in the sequence as
absolutely.
Yes.
Bhumi Chaudhary.
Yes, we can start.
Report of difficult intubation and ventilation.
Is not working.
Hello everyone, myself Dr. Sachin Devgade from LTMC Sion Hospital. I am presenting a case report of difficult intubation and ventilation in a case of penetrating chest trauma. Case history: a 33-year female, laborer by worker, and history of fall of iron rod from the height on the right side of the chest with a through and through passage of the iron rod. Before bringing to the hospital, nearby people had cut the rod from front and back. After patient received to our hospital with a clinical presentation, patient was conscious, oriented, and stable hemodynamically. On examination, there is no visible bleeding from entry and exit point of metallic iron rod. There was no external injuries. There is slightly reduced air entry in the right basis and audible heart sound was present. No added sounds, no raised JVP. Their abdomen was flat and soft. The palpable peripheral pulses was present and restricted right hand movement was present. And chest X-ray examination, no obvious bone fracture, no pneumothorax, no hemothorax, and no widening of the mediastinum, and no cardiomegaly was there. There is blood examination was within normal limit. After examination, all this case was taken for the surgery. For the surgery, anesthetic plan was in this case the plan difficulty was there. In the plan was the patient could not be made supine neither for intubation nor for surgery, for which difficult airway cart was prepared using video laryngoscopy along with the conventional laryngoscope, FRUA, Buji, and IGL. The endotracheal tubes was kept ready and the blood product was kept ready. After positioning and induction, patient was put on the left lateral position with adequate padding and supports wherever required. The patient induced under the propofol, atracurium, and pre-oxygenation. With the pre-oxygenation, head was tilted towards the right side and trachea was intubated using video laryngoscopy with ease out the process. The anesthesia maintained on O2, air, and inhalational sevoflurane and intermittent atracurium. There was one video regarding the intubation.
Yes, you brought it to then
Sorry, nothing can be seen.
जा अंदर जा थोड़ा बस चलो राइट द ड्यू
Yes.
See the black one. Yeah, very good.
Air entry was checked and confirmed after intubating, and every change in the position and thoracotomy was done. Unfortunately, very less part of the lung tissue was pierced with rods and which was not that much dangerous. Surgeon ligated the arteries around the rod and damaged tissues was resected after deflating the lung. The rod was pulled out and any leak was eliminated after inflating the lungs again by ventilating. Finally, the ICD placed in the pleural space and fixed to the skin in the right axilla. Patient was vitally stable throughout the procedure. Patient was extubated on table and shifted to ICU and then to the ward. Discharged to the home after 7 days of observation. These are the references for this case report presentation. Thank you all.
We now have 2 minutes for discussion.
Okay, Sachin, what do you think was the most uh, challenging part of this case? You're on mute, Sachin.
Yeah,
Please unmute yourself, Dr. Sachin.
Hello, am I audible?
Yes.
Regarding this case, ma'am, challenging part is the position of the patients, which is rod already present inside the
Correct.
chest.
So now you have given lateral position. Do you
Yes,
think
ma'am.
any other, did you have any other plan if the patient could not be made lateral? Any other position you could have given to this patient?
Propped up position which in the sitting position, that some angle with support to standing on bedside with
Yes.
some. Yes, ma'am.
Okay.
Okay.
Gedu sir?
well, when you got a problem of patient keeping absolutely supine also, why you have taken a risk of giving atracurium also along with propofol?
Sir, as this patient is having in the vitally stable, maintaining the saturation, not desaturating, and the
I'm not talking about the what you call the saturation and whatever your vital things. I'm talking about the positioning before you really intubate, because you are giving a long-acting atracurium.
Yes, sir.
So why you gave atracurium?
Sir, with that, with the use of the video laryngoscope, we will be managing this case with the video laryngoscope, and if we are not able to do that, we will use the supraglottic airway devices that for that.
Supraglottic airway devices for a thoracotomy, and that too with one lung collapse,
No.
was it going to be useful?
No, sir, that will not help. Yes.
And secondly, since you are going to do anyway the video laryngoscope and intubation was okay,
yes,
why you are not intubated this patient with a double limit tube?
Sir, as there was no much more leak, or the surgeon don't want to the double lumen to lung deflate on one side. They just want to remove the rods and then insert the ICD.
Okay, you can go now.
Okay.
Let the second one.
We'll move to the second one.
Yes, it is Arabic.
Greetings everyone, this is Dr. Dhanashree Chauhan, Resident Doctor MD Anesthesiology in LTMC Science Hospital. I am here to present a case on airway management in a case of recurrent nasal chondrosarcoma using video laryngoscope under guidance of Dr. Kanchan Rupavte and Dr. Manish Kotwani. Less than 5% of the chondrosarcomas occur in nasal septum. Because of the non-specific nature of the symptoms, it's difficult to diagnose it early. The primary modality of treatment is endoscopic excision, but the larger tumors require open surgeries, which require general anesthesia. The airway management becomes really difficult in these cases because of the mass effect causing deformities and obstructions in oral and nasal cavities. So my patient, a 65-year-old female, diagnosed nasal chondrosarcoma 7 years ago, had already undergone nasal endoscopic excision twice before. This time she presented with a painful swelling in right cheek, which progressed over 6 months, so much so that it caused the mouth forced open, causing distortion, bleeding, and loosening of teeth. She was a known hypertensive and diabetic on treatment. On airway examination, bilateral nasal blockages were present. The oral cavity was obliterated because of the protrusion of the mass into the oral cavity, and the Mallampati classification could not be commented upon. Although lab investigations were within normal limits, CT-PNA showed the lytic lesions involving hard palate and maxillary bone extending into the nasal cavity, posteriorly eroding the right maxillary sinus with complete erosion of the medial wall, inferiorly extending into the oral cavity with indentation over the tongue, displacing it left inferolaterally. Partial obliteration of bilateral posterior choana and right anterior choana was also present. Every step of induction in this case was difficult, including difficult mask ventilation, deciding whether to use sedation with IV sedation or inhalation anesthetic agent, and deciding the primary modality for securing the definitive airway. After thorough investigations and evaluations, discussions, and patient counseling, we decided to go ahead with video laryngoscope as a primary modality. So, after nasal oxygen insufflation, under minimal sedation with fentanyl and propofol, chest video laryngoscopy was done. Muscle relaxants was intentionally avoided to prevent the complications such as cannot intubate, cannot ventilate situations. on the primary chexoscopy, we could see the epiglottis and posterior commissure made it Cormac-Lahane grade 2A. So we went ahead with Bucci-guided intubation with flexometallic 6.5 cuffed endotracheal tube. However, if the Cormac-Lahane score would have been any worse, the only option we had was surgical tracheostomy. Fortunately, we were able to secure the airway with video laryngoscopy in this case. Anesthesia was maintained on oxygen, nitrous, isoflurane, dexmedetomidine infusion, and atracurium. Patient was well reversed, well extubated on table post-surgery. Like in any other difficult airway scenario, fiber optic bronchoscope was considered but ruled out because of the mass and obstruction in the nasal cavity. Nasal interventions were contraindicated. The oral fiber optic bronchoscope had limitations because of the distorted anatomy, fragile mass which tended to bleed, inadequate space to put the airway, and it would have been really uncomfortable for the patient to undergo awake intubation. Whereas video laryngoscopy required less space to enter, minimal manipulation, so less chances of bleeding, and minimal number of attempts also gave us better visualization of distorted anatomy and made it easier to manipulate. So the take-home message here is the appropriate mode of intubation should be decided after evaluation and discussion properly. Video laryngoscope is a very important tool in managing airway and should always be considered in difficult airways. In this case, it actually turned out to be superior than fiber optic bronchoscope. So I conclude here with that video laryngoscope is an important mode of intubation in GA, and in some cases like this, it could actually be our best option. Thank you so much.
Yeah, Dhanashree, I just want to ask you one thing.
Yes, sir.
With video laryngoscope and the way I have seen the patient's picture,
Yes,
was
sir.
it possible for you to manipulate along with the video laryngoscope also the endotracheal tube or the bougie from the sides?
Sir, there was not much space. That's why we tried primarily with check video laryngoscopy. And as we could see that we could actually enter smoothly, then only we went ahead with Bucci-guided intubation.
What did you give any oral anesthesia for the patient to tolerate video laryngoscope, and which number blade did you use?
Blade number 3 we used, ma'am. Straight
Okay.
blade, straight video laryngoscope with huge med video laryngoscope, straight blade number 3 we used.
And did you give anything to the patient to for this chexoscopy, or did she allow you to do?
Minimal fentanyl and propofol we had given, ma'am.
But then with this propofol, what was the chances that it would have got an obstruction?
Sir, we made sure she was spontaneously ventilating. We were watching for the ATCO2 to come. Spontaneous ventilation was still present when we were doing video laryngoscopy. And
why you didn't try the fiber optic scope? Because in fiber optic, at least you can railroad the tube.
Sir,
It's already, you can put the fiber optic scope through the tube. So you don't have to have an extra space for you to go.
Yes, sir, but to put a bite block, we didn't have enough space. And we thought because airway, the fiber optic bronchoscope would require more manipulation, and the mask was really fragile. It tended to bleed before also. So if
The Burman airway and video laryngoscope, I don't think there is much difference in the size.
Yes, I agree with you.
Yes. Means you could have this. See, this is we are just suggesting that this also could have been done. It's
Yes,
not that what you have did was wrong, but this
Yes, ma'am,
also was
definitely.
another option.
Yes, ma'am. Yes, ma'am. Thank you.
Okay.
Okay.
Thank you, sir.
We move to the next one now.
Yes.
Hello everyone, I'm Dr. Devanshi Gandhi, third year resident from the Department of Anesthesia, LTMMC Science. My topic is airway management in a case of upper lip hemangioma. Hemangioma is an abnormal malformation of the vascular endothelium. It's a benign phenomenon, mostly congenital, highly vascular, involving the lips and the buccal mucosa, tongue and the palate. Mucosal hemangioma is a well-circumscribed, soft, painless lesion which has a blue or red in appearance. Size, volume, location and hypertrophy leads to airway challenges and fatal complications. Here we present a case of 10-year-old female weighing 20 kg who presented in VIR with congenital swelling on the upper lip, progressively increasing size associated with nocturnal dyspnea. No other significant birth history was noted. Here is the picture showing the pre-op condition of patient with mouth opening of 2 finger breadth and MPC class 3. Lab investigation and coagulation profile was normal. MRI phase revealed 4 into 4.5 into 4 centimeter vascular malformation involving the upper lip and the right angle of mouth, and another 1 into 2 centimeter involving the right masseter muscle. Features suggestive of hemangioma. Surgical plan was to do diagnostic angiography followed by embolization of the feeder vessel and intralesional sclerotherapy. Anesthesia plan was to give general anesthesia. Options for securing airway are video laryngoscope with ETT. Second is the fiber optic guided ETT insertion, which remains the gold standard. And in emergency, tracheostomy, for which ENT surgeon was kept standby. Difficult airway equipment cart was kept ready. NBN was confirmed. Consent was taken, patient was taken, monitors attached, and IV secured. Glycopyrrolate and fentanyl was given. Patient was pre-oxygenated with 100% O2 using a bigger size face mask, number 3. Induction was done with injection propofol and scoline. We used best data VL scope with MAC blade size 2 without impingement on the swelling, and the airway was secured. Throat packing was done and eyes were padded. For maintenance of anesthesia, we use O2 nitrous sevoflurane plus intermittent atracurym. Injection tranexamic acid for hemostasis. Intraop dexamethasone was given for prevention of airway edema. Adrenaline-soaked gauze pieces were placed on the swelling for 10 minutes post-procedure for hemostasis. Awake extubation was performed in lateral position. Post-operative period was stable without complication and the swelling regressed gradually. Patient was monitored for 2 hours before shifting to the pediatric ward. Now, the challenges in this case were the patient was pediatric, airway, risk of airway obstruction, difficult airway, and the risk of bleeding and aspiration. Conventional laryngoscopy is difficult in such cases, so use of video laryngoscope guides in securing airway. Careful, gentle intubation, avoiding any trauma or pressure on the hemangioma prevents uncontrolled bleeding. Nasal fiber optic guided intubation remains gold standard management, which requires patient cooperation and hence is difficult to practice in pediatric population. LMS have the danger of dislodgement and risk of aspiration. Smooth extubation and avoid cuffing and gag reflex to prevent uncontrolled bleeding. Post-op hemangioma color changes and size increases due to surgical position and vasodilatory effect of the anesthetist, which further compromise the airway. Therefore, patient monitoring is required till swelling regresses. My conclusion is oral hemangiomas compromise airway and cause fatal complication, providing challenging situation for the anesthesiologist. Utility of the video laryngoscope and fiber optic intubation aids in safer airway management with lesser oral trauma in oral hemangiomas. These are the references. Thank you.
Well, since it is concerned with the upper lip, why you have not tried for the routine laryngoscope also? I think there should not have been a very big difficulty. Since you are already trying a video laryngoscope, which in fact takes a little bigger space than your routine laryngoscope.
Good morning, sir. Good morning, ma'am.
Yeah.
Sir, we had not attempted with conventional laryngoscope.
That's exactly what I'm asking. Why you not attempted that?
Sir, for the risk of any pressure on the swelling would lead to a lot of bleeding. Hence, we had avoided conventional laryngoscope and used video laryngoscope with a very soft and nice angulated blade, which prevented any trauma to the swelling, which prevented bleeding, sir.
I don't agree with that.
I don't
also
think there is a much difference.
Yeah,
Anyway, since it was a oral surgery, nasal tube would have been preferential, isn't it?
Correct.
So why did you not try nasal fiber optic bronchoscopy? Because this child was a older child, you could have easily tried that with lot of consulting and means discussing it with the patient. She would have allowed you.
Ma'am, first we tried to explain the mother. She was very apprehensive and they were not much cooperative. Patient was not much cooperative. Also, then we thought about the second plan. Since the mouth opening was 2 finger breadth, we attempted video laryngoscopy.
See, that's what I'm telling you. Since you have already given propofol and scoline, that means patient apprehension was having no importance at all. And after that, you could have still gone for a nasal intubation with a routine standard laryngoscope. That's what even Charu is saying.
Yes, ma'am, we could have gone. But since there was some mouth opening which was there, so we thought of attempting with video laryngoscopy. If we would have failed with that, we had given scoline, which was short acting. Our next step was to awaken the patient, give 0.5 mg per kg ketamine, 0.5 mics per kg dexmed loading, and attempt fiber optic intubation. Thank you, sir.
With all those whatever you have said, ketamine and all those things, low dose of 0.5 and all, that child would have cooperated you for a awake fiber optic intubation? Not possible. Since child was apprehensive, parents were apprehensive, you already told that.
Yes, sir.
Anyway, I think time is up.
Thank you, sir. Thank you, ma'am.
We move to the next presentation, please.
Hello everyone, I am Dr. Purva More presenting our experience of adult flexible intubation scopy in tertiary care center. Management of difficult airway is widely recognized as one of the important tasks. The problems related to it are known to be the primary causes of life-threatening consequences. Incidence of difficult tracheal intubation is 7.4%. The failure rate is reduced to 0.1% with standardized technique. Awake flexible intubation is an essential skill in management of patients with known difficult airway or who has an anticipated difficult airway. In this case series, we studied 7 cases of CA buccal mucosa, where we aim to evaluate the success rate and the challenges faced during awake flexible scope intubation. Here we included the patients of age more than 18 years with CA buccal mucosa having anticipated difficult intubation with restricted mouth opening. Written informed consent was taken and airway was prepared adequately using nebulization of 4% lignocaine, viscous gargles, and xylometazoline nasal drops. Regional block was given using 2% lignocaine, transtracheal block, and superior laryngeal nerve block. Oxygenation was given using nasal prongs. Pre-medication was given with injection glycopyrrolate 30 minutes prior. Adequate sedation was achieved with dexmedetomidine 0.5 mics per kg loading dose over 10 minutes and 0.5 mics per kg per minute maintenance dose. Equipment used with AMBO A scope and 5 scope. Let us see our observations and results in each cases. Our first case was having nil mouth opening. Adequate bilateral block was given and airway was secured using AMBO A scope in first attempt with adequate level of sedation. In the next case with 1 centimeter of mouth opening, we were only able to give unilateral block due to distorted neck anatomy, and airway was secured in second attempt by a senior consultant as the challenge phase over here was bleeding from mass was present. Because of this, the duration required for this scopy was also long, about 9 minutes. Then in next case with nil mouth opening, airway was secured in first attempt using 5 scope and with adequate sedation and bilateral block. In next case with 2 centimeter of mouth opening, patient we were not able to give adequate sedation due to hemodynamic instability, but airway was secured in first attempt using 5 scope. In next subsequent 3 cases, airway was secured in first attempt only using 5 scope and AMBO scope with proper sedation and bilateral block. Then in this case series, we report 7 cases of CA buccal mucosa with anticipated difficult intubation and restricted mouth opening for awake flexible intubation scopy. 6 out of 7 patients were successfully intubated in first attempt, that is 85.7%. There were no perioperative complications related to airway management. Management of potential difficult airway still remains a major challenge. Here we demonstrate that the AMBO scope and 5 scope can be used efficiently to accomplish an awake intubation in patients with suspected or known difficult airway. From this case series, we demonstrate that the standardized protocol, good airway preparation, appropriate equipment, and adequate level of conscious sedation and good expertise, difficult airway can be managed efficiently. Thank you.
Well, you have mentioned that there was no complication perioperative you have seen, but you also mentioned that there was one patient who had a bradycardia and hypotension.
Yes, good morning, sir. Good morning, ma'am. Sir, that was, we started sedation, we started injection dexmedetomidine. So at that time, because of that response, because of the drug, patient was not patient was going into bradycardia and hypotension. So we stopped our sedation and we proceeded with the procedure. We had not faced any complication perioperatively after that, sir.
Why these patients are not being given preoperatively high flow nasal oxygen so that you can have a much more time for you to intubate this patient? Because high flow nasal oxygen, if you give preoperatively, you can also have almost, I can say, 7 to 10 minutes of the time also for you to even intubate.
Yes, sir. Nasal oxygenation was easily feasible in our institute. We have not attempted. We have never tried of high flow nasal oxygenation yet. But we will surely see to it. We will definitely try again with the high flow nasal cannula and see how much time it requires for intubation.
And in one of the patients, you said that you have to give only unilateral block. Then
Yes.
I think in such a condition, you should have gone with a spray as you go type of also block.
Yes, sir. Yes,
that
sir.
would have helped you.
Yes, sir. In that patient, we tried using spray as you go in technique only, sir. So it was in second attempt we tried that technique.
When you say that you should have a standardized protocol, then you should be actually adding that spray as you go technique also in your protocol.
Okay, ma'am.
Okay, we can go to next.
Next one.
Respected seniors and judges, I am Dr. Mangal Dave, working at Gokul Super Speciality Hospital, Rajkot, and today I am presenting observation and documentation of minimal cervical spine movement during intubation with TASCO video laryngoscope. Neck movement and potential risk of damage to spinal cord during intubation is area of concern, especially in suspected or proven damaged cervical spine and inhibitus cord. Why? Because in order to intubate a patient, we have to align the oral pharyngeal and laryngeal axis. And to align these three axes, we have to extend the neck with conventional laryngoscope. To overcome the problem of extension, we are using endoscope camera attached to a specialized TASCO blade with a channel for bougie. And the TASCO blade is a hyperanculated blade and with a very thin margin and can enter the 1.5 centimeter of mouth opening. So practically we are bringing our eye inside the oral cavity and thereby removing all need of neck extension. We can, with TASCO, we can intubate the patient even in neutral position of neck. These are the videos of actual intubation with TASCO. The patients are conventionally induced and relaxed. In both the videos, you can see the neck of the patient is in neutral position, and with the entire intubation procedure, there is no undue neck extension which is required to intubate the patient. Once the patient laryngoscopy is done, the larynx is visualized, and then the bougie is first introduced. And once the bougie enters the larynx, then the endotracheal tube is railroaded over the bougie inside the larynx. On the right side in second video, you can see a lady with no neck or very short neck, introduction of TASCO, the visualization of epiglottis and the elevation, lifting of epiglottis, and seen are the vocal cords. Once the vocal cords are seen, then the bougie is introduced inside. So we did hundreds of intubations using TASCO, and we found that there is no much neck extension is required by intubating with TASCO. Another video showing a fixed neck patient where neck is fixed with Philadelphia collar, and we are intubating with TASCO with equal ease. We don't require any undue neck extension with TASCO. In the right side of the video is the actual screen what is seen in with TASCO. See the introduction of bougie inside and intubation. So to document these neck movements which are actually occurring during with intubation during TASCO, we did is we brought a C-arm and recorded the entire intubation procedure with C-arm fluoroscopy, and another camera we focused over us to document the entire procedure. See, the patient is conventionally induced and relaxed, and the entire procedure is also done fluoroscopy, and you can see the video of intubation of the same patient with TASC scope. The tube being introduced, intubation is done, TASC scope is taken out. On the right side is the fluoroscopy, actual fluoroscopy of the same procedure. And you can very well appreciate the neck movements. There is no undue neck movement or extension which can lead to any damage to the cervical spine. And see, the TASC scope blade has entered the oral cavity, and introduction of the bougie will be there. And once the bougie is there, there will be railroading of endotracheal tube, and then the TASC scope blade is taken out. But yeah, the intubation is done, blade is out. So there is no undue neck movement. To conclude, TASC scope video laryngoscope, which is a combination of hyperangulated blade with channel to introduce bougie, is very helpful tool for minimizing neck movement during intubation, and it can be a very useful adjunct in intubation in proven or suspected cervical spine cord injury. Thank you.
Well, Mangal, this was a good presentation, I can say. But only thing what I saw in your all videos, except one patient, other rest all the patient had no cervical collar that was being put up. Because even if you do whatever you are saying, there is a minimal movement or no movement. Even a minimal movement can damage the cervical spinal cord and all. So I believe you should have, done it with only one patient I saw. There was a cervical collar that was being put up.
Yeah, agree, sir. The two of the videos, initial two videos were non-cervical injury patients. The last two, one with Philadelphia collar and one we did fluoroscopy. Two were the cervical injury patients. I agree, sir. I agree with you.
Okay.
What are the other advantages of TASC scope that you felt that?
Madam, it can enter a minimal mouth opening, 1.5 centimeter mouth opening it can enter. And as it is having a channel for bougie, that is a channel which requires a very less space. And once the bougie is inside and we are viewing the things, it is very easy to railroad any size of like 7 or 7.5. We can change the endotracheal tube diameter. And that gives us a better facility rather than to have a single size of tube introduction facility channel. Having a channel for bougie is better than having a channel for endotracheal tube, which fixes us the size of tube. With bougie, we don't have fixed size. We can choose any type of tube to enter.
Okay, thank you.
Thank you, sir. Thank you, madam.
For the next presentation, sir, ma'am, we were supposed to have Dr. Sudha Puhal presenting according to the list, but unfortunately, I don't think she's joined us. We can listen to her presentation, but she will not be available for the question answer session.
Dr. Sudha, are you here in online in other name? Can you respond, please?
I had put the question across in the chat box, but she hasn't responded to that either.
I think we can take the next person, and then if she joins, we can take her later.
Sure, ma'am. No issues.
Yeah.
Is that okay, Manas? Can we do that?
Yes, ma'am. Yes, ma'am. It's okay.
So now we have Dr. Ashwini. Yeah, it's the next video. Thank you.
Manjari, that is.
Yes, Dr. Ashwini Vansari.
Child weighing 7 kg, which was admitted with a history of foreign body insertion in the throat 6 days back.
Good morning,
Following
everyone.
by the bleeding,
Myself, Dr.
bleeding
Ashwini
after the withdrawal of foreign body by the mother. Thereafter, the patient has fever.
Rishabh, please stop the video.
Then the diagnosis of retropharyngeal abscess was made.
Rishabh, please.
You'll have to restart.
Restart with single video. It's playing double. I think.
Yeah, I think so.
Hello, good morning everyone. Myself Dr. Ashwini Vansari, a third year anesthesia resident of Tata Memorial Hospital, Mumbai. I am presenting a case of anesthesia airway management for tubeless tracheal resection and anastomosis. Cervical tracheal resection and end-to-end anastomosis offer unique challenges like shared airway, management of ventilation, and maintaining depth of anesthesia. Different options for management of ventilation during cervical tracheal resection are cross-field ventilation, automated or manual jet ventilation, and apneic oxygenation. In this case report, we are presenting a unique approach of tubeless anesthesia during cervical tracheal resection and anastomosis. A 19-year-old male diagnosed case of non-obstructive adenoid cystic carcinoma of upper trachea was planned for endoscopy, tracheal mucosal biopsy, and SOS tracheal resection. endoscopy was performed using total intravenous anesthesia with an endotracheal tube of 5 mm internal diameter. After confirming the malignancy, surgery proceeded with the plan of cervical tracheal resection. We replaced endotracheal tube with Procil LMA number 4 and allowed spontaneous breathing when trachea was divided. Depth of anesthesia was maintained by TIVA using propofol infusion. Cuff reflex was obtained by using topical instillation of lignocaine intermittently. Avoidance of neuromuscular blockade enabled adequate spontaneous breathing, testing the integrity of nerves during surgery, and no need for reversal of neuromuscular blockade. So tubeless tracheal resection offers some advantages as well as some disadvantages. Advantages are complete non-interference with surgical field, faster surgery, lack of lower airway instrumentation, no ventilation-induced acute lung injury. Disadvantages are laryngospasm, which can be prevented by maintaining adequate depth of anesthesia, LMA displacement, which can be prevented by proper fixing of the LMA and the circuit, desaturation, less likely, but there is a risk of aspiration, which can be prevented by proper suctioning of gastric port of supraglottic air. So my conclusion was tubeless anesthesia is a safe, feasible, and effective option for tracheal resection and end-to-end anastomosis. Careful resection of a patient and understanding the physiological demand of the surgery hold the key for its success. These are my references.
Well, I just want to know one. Yeah, can I ask you a question, Ashwini?
Yes, sir. Good morning, sir.
Morning. I just want to know, since you have said that there is a tracheal resection you have done, and thereafter you are saying that the ventilation was maintained on a LMA, Procil
Yes.
LMA. How
Yes.
it is possible once you have done the tracheal resection, how your Procil LMA is going to work? I believe you should have put another microlaryngeal tube in the distal part of the trachea. That is, afterwards the resection part, the next part. That is the way you should ventilate.
So the patient is 19-year-old young patient, and prior to tracheal resection, there was a endoscopy and biopsy. During this procedure, we put a
You haven't understood. You haven't understood the question.
Exactly.
Please restrict yourself, because you will be wasting your own time.
Correct.
Restrict yourself to the answer.
Yes, I got question. We didn't put the small size endotracheal tube distally because the patient was maintaining, and we had a backup plan, like we put a Procil LMA, and just to avoid the limitation of access to the surgery.
That is exactly what I'm asking you again. That backup plan, your Procil LMA, how it works when you are done the tracheal resection.
Once the trachea is open, how your LMA is going to work, isn't
exactly.
it?
Yes, sir. We had a backup plan like apneic oxygenation and jet ventilation. So,
but how you are going to do the apneic ventilation? You are not told me that. What you put in the distal part of the trachea?
Yes,
and
sir.
You were giving only oxygen through the Procil LMA. I mean, for anesthesia, you were giving only TIVA, right?
Yes, sir.
So once the trachea was open, your Procil has it has become redundant, no?
Correct.
Yes, sir. So just to avoid the complications of distal airway instrumentation, like response to instrumentation and the prolongation of surgery, and if
Let me tell you, there is no complication that occurs with the distal instrumentation of the trachea also. Because I have given in Tata Memorial Hospital the resection of the trachea as well as cranial resection. And in that condition, I have intubated on the both unilateral, on right side and the left side of the principal bronchus, the tubes, and thereafter the anastomosis and all those things were done. So there's nothing, it doesn't matter whether you do a distal intubation or not. There's no issue about that. Your LMA is not going to work out for your oxygenation at all. Once you have done a tracheal resection, your oxygen will not reach to the alveoli. Am I right, Charu?
That's what I think. Although I do not have as much clinical experience as Gary.
I have done it in Tata.
Yes, yes.
As a patient,
Yeah, but it is very
he was maintaining saturation.
Yeah, no. See, your
So,
management
madam, how long
is
you will
excellent.
maintain?
We are just saying that ProSeal has no role once the trachea is open.
That's what I'm telling you.
Okay, I think we can go to the next one.
Thank you, ma'am. At the end, I would like to thank to Dr. J.V. Tiwatia and Sheila Mehta, ma'am, for giving me opportunity to speak over here. And I would like to thank to Dr. Swapnil sir in guiding me presenting this
We'll
case.
wind up now. Yeah.
Thank you.
Okay. You don't have to thank. You can thank afterwards.
Thank
Next.
Using direct laryngoscope. Good morning, everyone. My name is Dr. Supreet Singh. I'm a third-year resident at Tata Memorial Hospital, Mumbai. Before starting, I would like to thank TMC-DAC 2021 for providing me this opportunity to present my abstract over here. Also, I would like to thank Dr. Akansha who assisted me on this case. Also, I would like to thank Dr. Swapnil Parab who guided me during the procedure. So my case is a case report which discusses a unique approach of passing a bronchial blocker to ProSeal LMA for pediatric one-lung isolation. So let me just quickly take you through my case. So my patient is an 11-year-old, 136 centimeter tall, 27 kg female child with right lung upper lobe metastatic lesion posted for Pat's metastectomy. So what are the different options which are available in this childhood? As you can see in this picture over here, for a 10 to 12-year-old child, the different options which are available are either we can use a 26 French or a 28 French double lumen tube, or we can use a 6 mm single lumen ET tube with 5 French and blocker. So what were the options which were available to us and what were the options which were not available to us? In the CT scan, the tracheal diameter was of 9.2 mm. Hence, using a 26 French DLT or a 28 French DLT which has an outer diameter of 8.7 mm would have been difficult. Also, we have the unavailability of 5 French and blocker, and also the smallest pediatric bronchoscope which has the outer diameter of 2.8 mm was also unavailable to us. At the same time, considering the diameter of the available pediatric bronchoscope which has an outer diameter of 3.8 mm, passing a 7 French coupe deck blocker and a bronchoscope together through an ET tube of 6 mm would have been difficult too. Hence, we chose a unique approach and inserted a 2.5 ProSeal LMA carrying a pre-inserted 7 French coupe deck bronchial blocker. So how did we do it? Before inducing the patient, we checked our instrument, and only after smooth passage of both bronchial blocker and fiber optic scope through the LMA, we proceeded. After inducing the patient under general anesthesia, the bronchial blocker was passed beyond the cords by using direct laryngoscope. Only after passing of the bronchial blocker beyond the vocal cords, the LMA was placed in position, and only after confirming adequate ventilation with capnography and adequate tidal volume, the LMA was fixed. After fixation of the LMA, the bronchial blocker was placed in position under direct vision using FOB, and the one lung ventilation was commenced by filling 4 cc of air in the bronchial blocker. Throughout the process, the saturation was 100% and the peak inspiratory pressures were between 22 to 24 centimeter of water, which is less than the ceiling pressure of ProSeal LMA. So what are the advantages? So there is less risk of low airway instrumentation and trauma. It is suitable in patients with abnormal lower airway anatomy. What are the disadvantages? One is dislodgement of the bronchial blocker intraoperatively. Other is less suctioning of the non-ventilated lung. One of the difficulty which we found during our procedure was that we were having difficulty to pass bronchoscope beyond the cords through LMA. We were requiring some manipulation. I would like to conclude my talk by saying that achieving one lung ventilation in a pediatric population can be a challenging task. Thus, by thorough evaluation of pediatric airway dimension and by having a thorough knowledge of our available options, we can increase our chances of having a safe and successful one lung ventilation in children. Thank you.
What was the position in which the patient was operated?
Can you hear me?
What was the position in which the surgery was done?
I'm lateral position now.
Lateral position. So your proceal, you had put only proceal, so it did not. Yes, wasn't there a likely complication of the LMA getting dislodged during the lateral position?
Yeah, ma'am, that can happen. But in our case, that didn't happen, ma'am. Also, ma'am, we chose proceal LMA because in proceal LMA, because of the double tube arrangement, which is as there is less chance of displacement, ma'am. That's why, ma'am, we preferred proceal over other LMAs, ma'am.
And after putting the bronchial blocker, could you not have put in a smaller size endotracheal tube? I mean, because the size of the bronchial blocker which you have inserted is quite small. So there would have been a place in the glottis.
No, ma'am, that was actually the case, ma'am. So, ma'am, the smallest tube for this child, according to his age, as he's
standard endotracheal tube, I'm talking about.
Yeah, ma'am. So, ma'am, he's 10 to 12 years old. So, the ET tube which should be placed was either of a 6 mm tube or a 6.5 mm tube. And, ma'am, the size of the Coop-Tech blocker 7 French, which we used, was 3 mm. And the available fiber optic bronchoscope, which we have, was 3.6. So, if you add 3 of the Coop-Tech and 3.6.
So once you have, I agree that through the proceal, you have checked the bronchial blocker is in place. Could you not have then fixed the bronchial blocker, just withdrawn the proceal and put a smaller size endotracheal tube for the ventilation of the normal lung?
Yeah, ma'am, that we could have done. But ma'am, after putting the tube, once again, we have to check the position of the bronchial blocker. And with the bronchial blocker in place, it was difficult to pass the fiber optic scope along. Yeah, ma'am. That was the case, ma'am.
No, my question is, since you are putting the Coop-Tech blocker also, which is quite a big one size, whatever size 7 French you have said, I believe what Charu has asked you is a correct one. Even I would have gone one thing, you need not go through the endotracheal tube. You could have first put the blocker, and thereafter from the side also, you could have put a smaller tube also instead of LMA.
So we have checked that, sir. So we have checked that also for the site placement also. So there was not enough space, sir. First, we did the direct laryngoscopy. So the space between the cords and the tube was not that much, so that that it can pass through, sir. We have checked that too, sir.
Why not easy blocker? Easy blocker would have been a much more easier option.
So that could have been an easier option also, but for everything we require FOB, because FOB is the gold standard for confirmation.
For easy blocker, you don't need a FOB at all. It has got a bilateral like this.
Bilateral,
so
yes,
can directly go like that, and it can fit whatever.
So our time is up, unfortunately. We'll have to move to the next presentation.
Sorry.
Yes, sir.
Not fair. Next.
Thank you, sir.
Everyone, this is Dr. Sakshi Sharma. I'm third-year resident in the Department of Anesthesiology, Critical Care and Pain, Tata Memorial Hospital, Mumbai. I'll be discussing a case report with the title, Anticipated Pediatric Difficult Airway Management in a Case of Infantile Fibromatosis with Complete Trismus. Before beginning, I would like to thank Dr. Naina Amin ma'am for helping me out and my colleague Dr. Sukhpreet Singh, who was present with me during this case. Infantile fibromatosis, its peculiar feature is the local infiltration, and it most commonly affects the areas of shoulder girdle and fascia of head and neck. Picture below is my patient 5-year-old male, 108 centimeter, 18 kgs, which is a case of infantile fibromatosis of infratemporal fossa, which involved multiple facial-maxillary bones with complete trismus posted for right mandibulectomy. The challenges presented to us were, Due to this pediatric age group, the patient was uncooperative. He had a shorter apnea time because of the increased oxygen consumption, which resulted in limited time for instrumentation available to us. Awake intubation was not possible. Loss of airway control would have devastating consequences, and oral route was not an option for instrumentation due to the local infiltrative nature of this disease. Hence, plan A was sedated fiber optic intubation. Patient awake IV access was taken under EMLA in the preoperative patient holding area, and patient was wheeled in the OR. The anesthesia standard monitors, they were attached, and patient was induced with sevoflurane. Careful titration of the dose was done so as to maintain an unobstructed airway and spontaneous ventilation. Into the right nostril, we inserted a 5 centimeter nasopharyngeal airway, which was connected to the anesthesia circuit via the 15 mm adapter, so as to cause continuous delivery of the anesthetic agent and maintain an unobstructed airway. Then through the other nostril, a 3.8 mm of fiber optic scope, it was inserted with a mounted 5 millimeter of microcuff endotracheal tube. After visualization of the cords, the endotracheal tube, it was railroaded over the scope, and the tube position was confirmed with the capnography. Careful attention was paid to the correct sizing of the airways, fiber optic scope, and endotracheal tube. The procedure went uneventful, but the plan B, in case of failure of the sedated fiber optic intubation, was to wake up the patient, and if the surgery deemed necessary, we would go ahead with the elective tracheostomy. In a situation of can't intubate, can't ventilate, the option available would be emergency surgical access via needle cricothyroidotomy. Concluding, successful management of pediatric difficult airway is facilitated by pre-procedural assessment and preparation. As this case of infantile fibromatosis, it had multiple facial-maxillary bone involvement. This would be a nightmare for the anesthesiologist. Thus, the accessibility and continued hands-on training with the modern airway equipments and familiarization with the difficult airway guidelines and collaboration with multidisciplinary airway teams, which includes a trained airway provider, especially the pediatric anesthesiologist, an otolaryngist, and trained staff should be present in the OR at all the times for the management of this difficult pediatric airway. Thank you. Good morning, sir. Good morning, ma'am.
Morning, Sakshi. When you said that you put a nasal airway and you could see a good blast coming and you were maintaining oxygen, why you are not attempted a blind nasal? You should have just followed the same track. You would have been able to put the blind nasal as well.
So firstly, blind nasal, it has very less first pass success. It causes more trauma to the airway. We would have converted a well patent airway into airway. So in our institute,
I disagree that it is more traumatizing and less successful.
Sir, in your hands.
that Gauri knows that how much I was successful in blind nasal.
That's what I'm saying, in your hands, sir.
Sir, as the gold standard of an anticipated pediatric difficult airway, it is the flexible fiber optic endoscopy, and in our institution, it is available. So, sir, we went ahead with the flexible fiber optic endoscopy.
In that condition, there was no need for you to put one more airway in one nostril and second airway. I mean, in the second nostril, you would have gone with a fiber optic. Because the thing is, the nasal septum is pretty compressible on both sides. So you would have troubled on the both sides. So I think you should have followed the same track in one nostril only. You should have gone with the tube and all those things. How much was the mouth opening?
So the mouth opening was 0. So there was complete trismus. There was no mouth opening, 0 finger.
After sevoflurane also, there was no mouth opening at all?
No, sir. So because the disease process it was infiltrating to the multiple facial-maxillary bone. So even under sevoflurane, it was not possible to obtain any mouth opening.
Okay.
No questions from me.
Okay, done.
Okay, we move on to the next one then.
Next is
Dr. Sudha is here.
No, Dr. Sudha, I still can't see Dr. Sudha logged in. I think we move to the next one. That's Dr. Harsimran.
Dr. Harsimran.
Yes, please. Thank you.
Gauri, time is going.
Yes, sir. Yes, sir. Just give us a minute.
Where is your next one?
Yes, sir.
Myself, Dr. Harsimran Kaur from KGMU, will be presenting this very rare case report of this 4-month-old active baby who presented with a hemoglobin of 9.6 and a huge occipital swelling of 13.8 into 12.8 into 16.4 centimeter, which was termed massive because it was larger than the size of the head of the baby. And the MRI brain revealed that the sac contained not only the CSF, but a part of occipital lobe, the posterior fossa contained, and venous sinuses herniation, everything correlating with the findings of Chiari malformation type 3, and which is a very rare condition because the incidence of encephalocele is 1 per 5,000 live births. A detailed explanation of her condition along with the prognosis and all the complications and possible outcomes were given to her parents, and the consent was taken. And before taking up the patient to the OT was adequately warmed up, and other than that, all the necessary preparations for managing the difficult airway, like the difficult airway card, other modes of ventilation were kept ready. Patient was placed in the lateral position in order to prevent undue pressure on the encephalocele. All the standard ASA monitors were attached, along with the precordial stethoscope and the temperature probe. 24 gauge IV cannula was secured, and warm isolite P was started at 15 ml per hour. Drugs used were glycopyrrolate 0.03 mg IV, fentanyl 10 mics, and thiode 20 mg IV for induction, while muscle relaxation was achieved using scoline 5 mg. So laryngoscopy, when attempted in this position, it provided a Cormack-Lehane grade 3. Only the tip of epiglottis was visualized. So ventilation was continued in the lateral position itself, and the patient was lifted up, and her head was placed beyond the edge of the table with an assistant who was supporting the head, another assistant who was stabilizing the patient's body. Everything done in order to prevent the premature rupture of the sac. So when laryngoscopy done in this position provided a Cormack-Lehane grade 2, and the airway was secured using 4 millimeter internal diameter uncuffed endotracheal tube. After the bilateral air entry was confirmed and proper tube fixation, the baby was made prone for the surgery. Injection atracurium was given, and anesthesia was maintained using oxygen, nitrous, SIVO, and injection atra. Complete resection of sac, as you can see, was done without any complications, and all throughout the surgery, meticulous temperature monitoring as well as the fluid monitoring was done, and the blood loss of 70 ml was replaced by transfusion of 70 ml of blood. At the end of the surgery, the patient, when was noted to have spontaneous respiratory efforts, was reversed using neostigmine and atropine, and was extubated when good motor activity returned, and was shifted to ICU for further monitoring and for oxygen support. So this case shows that if there is an expertise in handling the airway, and there are novel ideas developed for the management plan, the patient will have a successful outcome. As we were ready for all throughout the intubation, we were ready for all conditions. So we could easily manage and secure the airway despite the difficult airway. And this case also shows that these patients also pose other challenges, like they're more prone for serum electrolyte imbalance, more prone for hypothermia due to central autonomic dysfunction, as well as large surface area. There are more prone for excessive blood loss and latex allergy, which might lead to bronchospasm. If there is any neurological insult intra-op, it might lead to post-op seizures. And the sudden loss of CSF and decompression of ventricles might cause traction on the brainstem nuclei, causing bradycardia and cardiac arrest, which are other problems other than the pediatric airway, which generally anyways is challenging for the anesthetist. But still we had a successful outcome, and it is proven if the proper management plan is done, then such patients will definitely have a successful outcome as seen in our case. Thank you so much.
Hello. Is she there?
Yes, ma'am. She's here. I can see her in the panel.
because I can't see her video.
I don't think she that's her, ma'am.
Yeah.
Turn it on.
Parsimran, you have mentioned about airway plan, but you have not discussed what did you keep ready? What was your failure backup plan A, backup plan 2? You didn't mention anything. What special airway gadgets you had kept ready?
Sir, ma'am, I told about the difficult airway cart which was kept ready. The difficult airway cart.
What did you keep?
The supraglottic airway devices were kept, ma'am, in the difficult airway cart, along with the pediatric bougie was there, and stillate was present, and other modes like for cricothyroidotomy also we had made preparations.
What about video laryngoscope? Did you keep video laryngoscope?
Ma'am, video laryngoscope was not available actually, so.
Okay. Dr. Gedu?
Ma'am, I can see him logged in, but his mic appears to be off. I'll just give him a call for a second.
Yeah. Why did you not try intubating the child in the okay? Gedu is.
अरे यार यहाँ पे मुझे क्लैरिटी नहीं हो रही थी, पता नहीं, they were not connecting at all. It's not connecting. Something has gone wrong.
No, you are audible.
Hear me now?
Yes, yes, we can hear you.
Okay, just one thing I just want to start with you. First thing I want to ask is, first thing, I think you should have made slides because this was very much micro type of the pictures. I could not read it properly. But in any case, this was a very much standard technique that we used to do in our college days when for all these hydro.
Hello, sir.
We appear to have lost her again. Hello. Sir, may I put you, if it's okay with you, I'll put you on speaker and then you can ask the question. मेरे फोन का स्पीकर डाल के मैं आपको यहाँ से कनेक्ट करती हूँ. Yes. Can everyone hear sir? Sir is unable to connect, so sir will be speaking on speaker from my phone.
Yes, sure.
Can you hear? Can you hear him, Arsimran? Sir.
Hello.
Can hear you.
I just wanted to know when you knew that it is going to be.
Ma'am, it's not audible, ma'am.
Gauri, you can listen to what sir is saying and you can ask.
Taken at the age that the way we used to do in our college for our
Sir, yeah, sure, ma'am. Ma'am, sir is asking that if you knew it was a difficult airway, this is a fairly standard technique. Why was the head just not moved to the edge to begin with?
Exactly what my question was.
Actually, ma'am, this is because I have read many studies before also which have been done in lateral position, and that is what I told, that some novel ideas have to be implemented, like for other successful. In other cases also we can apply and we can see if this method is successful or not. And we had tried also before also on a baby with the hydrocephalus. We had done intubation in lateral position, which was successful. So we made an attempt in this case also, but in this case,
it's a good thing that you did a check scopy. However, it is not a novel idea. That's what we are trying to say.
Okay.
I just want to ask one more thing, Gauri.
Yes, sir.
That when you know there is such a big head circumference, I believe you should have kept a lot of pillows or something like pads below the chest wall and the neck, so that it would have come in the same
Sir, I'll point that out. Sir saying that since we know that the head circumference is so big,
what might have been better is if you would kept pillows under the thorax and the abdominal cavity and allowed the head to rest on the OT table itself instead of allowing it to hang dangerously off the OT table. You could have moved the baby. You could have moved the baby to the table, put the pillows under the baby, and allow the head on the table itself.
It was not, the head was not hanging actually. So the head was supported by an assistant, and an assistant was supporting the head as well as one was maintaining the inline stabilization of the baby. So there was no.
So what I'm trying to say is you should have brought everything that is right from the
Am I
head
audible?
down to the
Yes,
chest.
sir.
Everything by keeping pillows and should have been brought at the same level.
Yes, sir. So
Then it doesn't become difficult.
yes, sir. So what her reply is that their head was not unsupported. They had an assistant supporting the head, and they achieved that with the baby's head hanging. The same thing that was proposed. So actually our time is up. We'll move
Yeah,
on.
I think we can go to next.
Thank you, sir. So I'll thank you.
Thank you.
Airway management of post-1 contraction in patient with microstomy. Liver presentation of post-1 may be scar hypertrophy, atrophy, or contracture. In contracture, skin over the butt area constricts and reduces the range of movement if it presents over the joint. Honor proposes the classification system of post-1 over the neck. In grade 1 is a mild anterior contracture of neck. Grade 2, moderate anterior contracture of neck. Grade 3, severe anterior contracture of neck. And grade 4, posterior contracture of neck. In grade 3, the severe anterior contracture of neck. There is a fixed flexion deformity of neck. Extension is limited, which reduces the oropharyngeal laryngeal space, therefore making airway difficult. The layers involved are skin, subcutaneous tissue, and strap muscles. In my case scenario, a 40-year-old male patient weighing 65 kg, ASA class 1, with honor grade 3, severe orofacial neck and trunk burn presented to us for elective expedilaterotomy. My airway assessment was mouth opening, one finger. Melanopathy examination can be assessed because of fixed flexion deformity of neck. Assessment of a thyromental and sternomental distance cannot be done. Routine investigation was done. X-ray showed an acute angulation of airway at the level of glottis. Preoperatively, informed risk consent has been taken. My airway management will be awake nasal fiber optic intubation with surgical airway management as a backup plan. Intraoperatively, fiber optic assembly has been checked. My difficult airway card checked. My drug set checked. Emergency drug has been checked. And then proceeded with standard monitoring of ECG, NIBP, and SpO2. Patient has been nebulized with the lignocaine 4%, nasal preparation done with xylometazoline nasal drops and nasal packing with the 2 ml of lignocaine 2% in combination with adrenaline soft cool. Tonsillar area anesthetized with lignocaine 10%. Injection dexamethasone started in a loading dose of 1 microgram per kg for 10 minutes. Pre-medication of injection ondansetron, glycopyrrolate, midazolam, and fentanyl has been given in appropriate dosage. Intravenous ketamine and propofol given in small liquids, maintaining spontaneous ventilation. Adult site bronchoscope with 7 mm AT tube threaded on it and advanced through nasal cavity. Pharynx and larynx has been anesthetized with lignocaine 2% spray as you go. After weighing glottic opening, tracheal lumen was confirmed by visualizing tracheal rings. Then ET tube has been advanced and patient has been intubated. After confirming intubation by auscultation, cisatrocum in a dose of 0.2 mg per kg given. Patient mechanically ventilated. Anesthesia has been started and maintained with oxygen, air, and sevoflurane. Injection dexamethasone kept in a maintenance dose of 0.2 to 0.7 microgram per kg per hour. Intraoperatively, period was uneventful. Patient was extubated when patient awake and spontaneously breathing after reversal of neuromuscular blockade. I conclude successful anesthetic management when the airway is inaccessible and distorted by post-1 contracture implement its planned approach for securing airway, including use of fiber optic devices. My references are Indian Journal of Anesthesia and Egyptian Journal of Anesthesia.
Here you have written that 10% xylocaine was used to anesthetize the tonsillar area. Does that mean you had given injections, means the mouth was open, or how did you give that, or it was a spray?
As a spray, because there was a limited mouth opening, but it was a one, mouth opening of one finger. So via spray, we anesthetized the tonsillar area.
Okay. Suppose if you had not had access to fiber optic bronchoscope, what you would have done?
And there are other methods like lighted stillets, optical stillets, and retrograde intubation.
Retrograde intubation, okay.
Yeah, there's other methods like.
Would you have been able to do retrograde, because there were so many contractures on the neck? I don't think retrograde is a choice at all in this patient.
Yeah. And other method, we can do that we can release that contracture by giving a tumescent anesthesia or by nerve blocks. Then we can proceed with intubation.
Right. Dr. Gedu? I think he has logged in now.
He's logged in, but he's not unmuted himself. Maybe he can't hear us yet. No, ma'am, he can't hear us. Ma'am, the next participant has not come. She's not joined us. So this will be the last presentation for the day.
This will be the last.
Yes, ma'am.
Okay. Does Dr. Gedu want to ask anything for the last contestant, the one we finished just now, Agarwal? Are you trying to call him or anything?
Yes, ma'am, I am. Ma'am, but he's
I
not.
mean, just,
Yes, ma'am, I'll just give him a call again.
Yeah.
Howdy.
Yeah, he's
Howdy,
there.
We can hear you now, sir.
I think he's on phone right now.
I will.
1 second, I'll put you on speaker. Yes, sir, you're on speaker now.
Yeah, the case is finished already?
Yes, sir.
Just I got a question that if this burn patient, of course, I'm not seeing the picture at all, but if the burn patient has got a contraction where your chin is almost touching your neck or chest wall, whatever you want to say.
Yes, sir.
How is she going to intubate this patient?
Sir's asking how.
By the way, which hospital she belongs to?
Supriya, sir would like to know what hospital you belong to.
Mahatma Gandhi Institute of Medical Science, Sevagram, Wardha.
Sir, Sevagram, Wardha, she's from. And sir's asking if you had a patient whose chin was almost touching the chest because of a contracture, how would you go about it? Which is, I think, sir, this is how her case was. And they'd done an awake fiber optic with dexmedetomidine pre-medication sedation with dexmedetomidine. They did a spray they sprayed as they went, and they sprayed the tonsillar fossa with 10% lignocaine.
Sorry.
Yes, sir.
I just want to ask her one thing.
Yes, sir.
Well, anyway, because I'm not gone to the case at all, I cannot comment on that.
Yes, sir.
But I just want to ask her one thing. If you don't have fiber optic, how are you going to proceed?
Sir, Charu ma'am asked her what she would do in the absence of a fiber optic. She initially said retrograde intubation, then followed it up with tumescent anesthesia to release contractures.
Again, I will say that retrograde is not possible in this patient.
Yes.
For the simple reason because you cannot have any landmark on your neck also.
Yes, sir. So Charu ma'am pointed out that it's not possible to do a retrograde in this case because of the contractures, and she would have to proceed alternatively. So to which she replied with an tumescent anesthesia to release contractures. Sir.
even tumescent may or may not work for the, when there is a lot of fibrosis over there, so your tumescent anesthesia may not reach
Yes,
the
sir.
point where that your nerves are going to be.
Yes, sir.
So how you are going to protect them?
Supriya,
Yes,
do you have
ma'am.
an answer for that? Sir saying that tumescent anesthesia also may not work because you may not be able to infiltrate the nerves.
There might be lighted steroids, so we can proceed with a blind nasal intubation through the lighted steroids.
So she says blind nasal intubation with a lighted stellate.
Again, blind nasal lighted stellate again will not work because your light will not be seen in the anterior part of the neck.
Yes.
And secondly, blind nasal will not again work because the patient is in a deep flexion.
Yes, sir.
So how will you proceed for this patient? But I do have an answer that I can study what yeah, Gauri.
So she's waiting. She's thinking about it, sir. She's asked them, sir.
Actually, what a question. Because
Supriya, did you hear the question, right?
Yeah. Yes, ma'am. I got it. That because of the contracture, we won't be able to see
Correct.
that.
We won't be able to see the lighted stellate. Blind nasal may not be possible. So what is your alternative then? So I don't think she has an answer. I have mine. May I tell you?
Yes.
Call Gedu sir for help, and then say I can't do the case. Sir, elective case, sir. I'll wait. So with this, I think we'll have to close this session.
Yes.
We've overshot the time.
Okay.
with you, Gauri.
Yes, sir. No problem, sir. No problem. Okay, no problem. Thank you so much, sir.
Okay, thank you so much. Sorry, in the last two cases I could not do it.
No problem.
And I believe that one girl that Shiva was not there.
No, sir. Sudha has not joined us. Thank you, sir.
Okay, remaining I'll just click photo shoot and I'll just send it to you.
Yes, sir. Thank you so much, sir. Thank you so
Thank
much,
you.
Charu ma'am, for your patience.
Thank you, Charu madam, and thank you, Gedu sir.
Thank
you very much. And thank you, Gauri
Excellent
madam.
presentations, really, everyone.
Yes. Thank you. Thank you so much.
Rishabh, please play the Meet the Expert.
Yeah, sure.
Manas, should we start the session?
Ma'am, we'll start at 3:45, 3 minutes late now.
All right.
Hi, Rakesh. Hi, Sakada.
Hi, hello, sir. Good afternoon, sir.
Good afternoon. Oh, good morning from London, and good afternoon.
Yeah.
Rakesh, I'm glad you chose the right coloured shirt to wear, so we're matching, which is good.
It will be an honor to match you, sir. You're a stalwart in airway, so it will be an honor to match you. All well, sir? All well?
Yeah, it's all good here. I've been watching the conference. It's all going very well, very smoothly.
Yeah, absolutely going well, sir. And a lot of appreciations because of all of you, because great contribution and a lot of stalwarts in the conference. So
yeah, no, it looks like it's going very well.
We'll just start in a couple of minutes, sir.
Yeah, absolutely. So Dr. Bangera is with us.
Good afternoon. Good afternoon, Dr. Rakesh. Good afternoon, Dr. Imran.
Yeah, good afternoon, sir. So I think in another 2-3 minutes, we'll start with, is it Dr. Sukada?
Yes, yes, sir.
Is this session working by people are going to join live, or they're going to send questions in? We're going to send questions in. Okay, then we'll just
yes, sir. Yeah, yeah.
Okay, that's fine.
So I think we should start. Welcome to the Meet the Experts session. So today we have the privilege to discuss two very interesting topics by esteemed faculty. So I request all the delegates not to miss this golden opportunity to clear all your doubts and queries. So we'll start with the first topic. So first topic is everything you want to know about awake tracheal intubation. And I invite Dr. Rakesh Garg, Additional Professor of Anesthesia at Dr. B.R. Ambedkar IRCH, AIIMS, New Delhi, and Dr. Anand Bangera, Professor in the Department of Anesthesiology, Critical Care at KS Hegde Medical Academy, Mangalore. Over to you, Dr. Rakesh and Dr. Anand.
Dr. Rakesh, you need to unmute. Dr. Rakesh.
Thank you. Thank you so much, Dr. Sukada, for your kind introduction. And welcome, Dr. Imran Ahmed, who is, I think, a well-known personality. He probably does not require even a slide, because each one of us across the globe, not only in India, knows about his great contribution in many aspects in the field of airway. He is a consultant anesthetist at Guy's and St. Thomas NHS Foundation Trust, London, UK. He is honorary secretary of Difficult Airway Society. He is honorary senior lecturer at King's College, London, UK. He is education lead for Airway Fellowship, and he has a very special interest in airway assessment in patients with difficult airways, and is pioneered in the use of virtual endoscopy for airway assessment. He has developed novel techniques for airway management, which we all very well know. He is one of the pioneers for difficult intubation guidelines, and he is one of the lead author for guidelines for awake tracheal intubation in adults. He has a special interest in difficult airway management and is a clinical lead for airway management at the Trust. So I, along with Dr. Anand Bangera, welcome you, sir, for today's Expert the Meet program.
Good morning from London, and thank you very much for inviting me and for your lovely introduction. I just wanted to add that I sent that in a few, I think probably a month or two ago. And since then, I've been lucky enough to be promoted as the president of the Difficult Airway Society now. So it's a slight update for you.
Sorry, absolutely. Congratulations. I think we missed it. So sorry for that. So I think any opening comments from your side for today's, when we talk about the awake tracheal intubation. I think when we talk about the awake tracheal intubation, what are the key points where it will be a trigger factor or maybe a factor that will make us decide that this patient is only suitable for awake and we should not venture in any other plan under GA or spontaneous or something else?
That's a really good question, and it's a really good way to start this whole discussion, because this is partly why I wanted to write the guidelines. I think if you look at previous studies like the NAP4 study, there were many cases where the reviewers felt that an awake intubation should have been done, but the anaesthetist decided to go for a sleep intubation and then ran into trouble, and that's how it was reported in the NAP4 study. Interestingly, the vast majority of those anaesthetists were consultants or experienced people, yet they chose to put the patient to sleep despite finding or predicting the patient would be difficult, but they decided to put the patient to sleep and doing a sleep intubation, and then they struggled and hence they ran into complications. So what is the trigger to go for an awake intubation? And when we wrote the guidelines, we really wanted to make it as broad as possible. And my trigger is in any situation where I feel that a sleep intubation is going to be difficult, then I have a very low threshold to do an awake intubation. And the reason for that is because I know that if a patient is predicted to be difficult and I put the patient to sleep, the risks are much higher than if I decided to do the intubation awake across every aspect of airway management. So from face mask ventilation to laryngoscopy to intubation to insertion of front of neck access. Every aspect of airway management in predicted difficult airways is more difficult when the patient is asleep compared to when the patient is awake. And therefore, for me, if there's any patient who I think will have a difficult airway in some regards, then I will definitely consider an awake intubation. And that's what we try to encourage to everybody, because we know the data shows that if you think it's going to be difficult, you put the patient to sleep, it's more likely to be difficult than if you did the intubation awake. And that's a very broad answer, but I think that's the thing you need to consider, and that's what we wrote in the guidelines.
Absolutely. I think, do you think with regards to the awake and versus under GA, do you think the experience of the person is also an important consideration? Because maybe a person like you would be good enough to use the video laryngoscopy in a difficult intubation. But on the other hand, maybe a novice person who may not have handled so much of difficult intubation, the same which becomes easy for you may be difficult for a person who is novice into those things. So, and second point, even for awake tracheal intubation, there would be some learning curve. So, for example, say if I have not done any awake tracheal intubation and one fine day I find a difficult airway which mandates to be awake, should I go for it or should I follow some other strategy? Your comments.
Yeah, I mean, again, that's the whole point of lowering your threshold. If you lower your threshold, you will do more awake intubations. Again, if you look at the case series published across the world, really, for the number of, when they publish big series of awake intubations, we published 350 awake intubations, 550 awake intubations. Others have published more or less 1,000, 500 up to 1,000. And in all those case series where they did lots and lots of awake intubations, those units did about 1% of their intubations awake. So it's a very small number. So this is like where I work, we do 20 or 30 a month. And despite that, only about 1% of our intubations are done awake. It's even less in other hospitals. So if you are only going to do awake intubations less than 1% of the time, and you have a patient who is predicted to be difficult, then you're less likely to choose a technique that you're not familiar with, which is an awake intubation technique. and that's the problem. The problem is that we're trying to do a technique that is technically challenging, and there is a learning curve, as you say. But if we don't do it more often, we're never going to get good at it. And when we genuinely need it in a difficult situation, then that's the time where we need our training and our practice. So if you lower your threshold, if you do more awake intubations, you get better at it, you get more familiar with it. And then when you genuinely do need it in a case where there's no other option, then you're more likely to use that technique and succeed in that technique. So my advice always is, my teaching always is yes, you need to have an indication, but lower your threshold, do more awake intubations, get good at it, because if you're good at it, then you're more likely to use it when it's a very, very difficult situation.
In your experience, how much you think would be the approximate learning curve? Maybe we are trying for normal intubation and go for awake for a learning purpose, for getting an expertise. But how do you think, how many difficult airway we should go for awake intubation under supervision before we venture into doing it individually as a consultant in charge, or for any person who is working alone? Approximately how many numbers do you think would make him comfortable?
Yes, so that's a difficult one to answer, because everybody is so variable in their learning curves, and actually the complexity of the situation varies as well. You know, if you've got a max difficult airway where the mouth opening is limited, then that's relatively easy because you go through the nose and there's no pathology in the airway. Whereas if there's a patient with a big tumor, a supraglottic tumor, then that's technically more difficult. So that will take a lot more of a learning curve. With my airway fellows, we normally have sort of 10 to 15 in a short period of time. And by that point, I'm happy for them to be doing them alone, but with some sort of distant supervision. But it's not just about gaining competence, it's about maintaining competence as well. So you may do an airway fellowship and do 50 intubations in a six-month fellowship, but then you don't do any more intubation for the next 5 years, then you're back to square one again. So you need to try and maintain that as well. And that's challenging because, as I said, less than 1% of our intubations are done awake. So it's about learning different aspects of awake intubation and trying to maintain that level of competence.
I think very important message is coming from Dr. Imran, and he's a pioneer in the airway management for many decades now. It's just not learning or getting a training for 6 months or a year as a fellowship or as a fellow somewhere, but it's also very, very important to maintain your competency. That's why each technique over months and years, we need to repeat it every time so that the tension of that skill is maintained. And this is an important aspect for everyone. If I'm an expert today, I know I can do awake trachea intubation, but if I don't do it for the next 5 years, at the 6th year, I may not be the expert. I may be like a novice because I have not done it for the 5 years. So I think retention and maintaining the competency is one of the human factor that needs to be considered for this. Dr. Imran, I was just going through your guidelines, and you have very nicely mentioned about the ergonomics of awake trachea intubation. Many of time we miss it. I've seen many scenarios that in the operating room where a difficult airway is being handled, there may be 10 people, but the people are in chaos. At which position, who is standing, who is the expert, who is the assistant? It creates a lot of confusion inside the operating room. There will be 3 anesthetists, there will be 2 operating room technicians, maybe surgeon. So what do you suggest? What's your experience that how should we arrange the ergonomic inside the operating room when we are managing the difficult airway? I think majority of time we miss it. We read the algorithms and guidelines for managing an airway, but those preparatory part and those arrangement in the operating room sometimes is one of the key factors for success. So what do you suggest about it, sir?
Yeah, it's very important. So the non-technical skills in terms of positioning, in terms of where you stand, where your assistant stands, where your monitoring is, where your scope is, all these things are really important. And as you said in the paper, we've actually made diagrams of where we think you should stand. So you think about it. So again, it depends on the setup of your theatre, your anesthetic room, what's possible, but thinking about it is really important. Simple things like where you put the monitor. If you're facing the patient, you want the monitor So you just have to move your eye line across, as opposed to doing this and looking this way while the patient is in front of you. So I've seen that happen many times. So ergonomics, when you get to my age, you need to think about your neck and your back and your positioning. The youngsters can get away with it, but the more you do, the longer it is, the more your body feels it. So think about where the patient is, think about where your monitor is, think about where your assistant is, and have everything nearby. And also you just have slight movements for your vision, and also so that you can see things. You need to see the SATS monitor. You need to see the patient is breathing. You need to see the patient as well. You need to see the monitor. You need to see your equipment, and things can change very quickly. And if you have your ergonomics correct and right, then you're less likely to run into trouble. I mean, only last week, one of my colleagues was telling me that she was doing an awake intubation, and she asked for the high flow nasal oxygen. They didn't know what it was. They connected it up. She was doing the awake intubation. Patient started to desaturate. She noticed that there was no flow through the high flow nasal oxygen. And but what she realized was the nurse had attached it to an oxygen cylinder, and halfway through the procedure, it ran out of oxygen. Now that wasn't the nurse's fault. The nurse didn't know. It was the anesthetist's fault. The anesthetist should know that you need to run it from a pipeline supply, because it runs out if you don't. And because the position of the optiflow was behind her, she didn't notice this. And that's why it's really important that you think about these things beforehand. Think about your positioning, and you are primarily responsible for this. And if you can't see these things, then these things can go wrong. And there's a very simple thing like giving oxygen can become a problem. And that's why ergonomics is so important. You pick up on things because you can see them. You're comfortable. You're not as tired. If you hold the scope for too long, your arm starts to ache. If your neck is in the wrong position, you start to fatigue. So all these little things that you don't normally think about are really important. And it just makes a technically difficult thing even more difficult if you don't do it properly.
Dr. Imran, I'm Raj. Can you hear me?
Yeah, Dr. Raj, yeah, please.
Hi, Dr. Imran, what percentage of your awake tracheal intubations you use fiber optic, and what percentage you go for a video laryngoscope?
Again, a very good question. So we primarily did 100% awake intubations with a flexible bronchoscope, because that's how we were trained, and everybody thinks about an awake intubation is synonymous with a flexible bronchoscope. That's when we first started to write the guidelines. The reason why I changed it to awake tracheal intubation from awake fiber optic intubation is because awake fiber optic intubation means you're using a fibroscope, whereas awake tracheal intubation means you can use any device because you're intubating the trachea awake. And now most commonly it's a flexible bronchoscope. That's my default, and that's what I trained on. But I'm starting to do more and more awake video laryngoscopy intubations. I would say the numbers are still quite small, so maybe 95% versus 5% or 90 to 10. And the reason why I'm doing my 10% with a video laryngoscope is because I'm training other people how to use it. But I think in 5-10 years time it'll be 50-50 and maybe even more VL compared to flexible bronchoscope. And the reason for that is because we're all very familiar with using a video laryngoscope. We're using it even more since the pandemic started, and we're becoming much more familiar with how to use them. And secondly, it's easier to train an awake intubation on asleep patients if you're using a flexible bronchoscope. So if you have the patient sat up and you put them to sleep, you can practice your video laryngoscopy technique, which is more replicable. You can replicate it very similarly to when they're awake. Because they're sitting up, you're facing the patient, you can practice that technique and then do it in an awake patient. Whereas with a flexible bronchoscope, when you're doing it asleep, it's very different to when you're doing it awake. So I think our training, our familiarity, our experience with VL will mean that in the future we do more and more awake VLs than we do asleep VLs, than we do awake flexible bronchoscopes. The next question I get asked a lot in relation to this is when would I do an awake VL compared to an awake flexible bronchoscope? And the answer to that question is if I ever want to visualize the tube going through the glottis then I would use a video laryngoscopy technique, because with a flexible bronchoscope, you can't see the tube going through the cords because your scope is already in the trachea. So the railroading is blind. So if I ever want to watch my tube go into the trachea, then I would use a video laryngoscope. For example, if there's a tumor there or something, is in the way, and I want to make sure I don't dislodge it, or I want to make sure I go around it, then I will use an awake VL technique. Also, sometimes.
Sorry. So if you're planning, will you do something like a hybrid technique with a CMAC where you can shift between FOB, means fiber versus VL?
VL. Yeah, you can use a combined technique as well. And I've done that many times. Actually, that's probably, I've done more than just use a VL technique. And the hybrid technique is where you have one person who holds a video laryngoscope and a second person who holds a fibroscope. And you do both at the same time. As the operator, your eyes are on the view of the flexible bronchoscope, whereas your assistant is looking at the VL view. And what you're doing here is you're physically opening up the glottis, and then you're using your scope as a bougie, basically, and then you're railroading the tube over that. The only problem with that technique is you need two people. You need one person to hold a video laryngoscope and one person to hold a flexible bronchoscope. There's a new device called a ProView, which is an optical stylet. And I've been using that quite a lot recently, because what that allows you to do is to do both yourself. So I can hold my video laryngoscope in one hand and the tube with the other hand with the ProView, and it allows me to coordinate it and do both myself. So it's a single person technique, but I'm still using the video laryngoscope as well as the optical stylet. The problem with the flexible bronchoscope is you need to hold it with two hands. One hand needs to hold the scope, so therefore you can't use your other hand to hold the video laryngoscope. So that's why you need a second person. But I quite like the hybrid technique when I'm doing both myself, because I can coordinate it better. And so I quite like using the optical stylet for that reason.
Rakesh, can I ask one more question?
Yeah, please.
Yeah, please, sir.
Okay. Yeah. So when you talk about an awake tracheal intubation, sometimes we may wonder when to add in a sedation, because we don't have remifentanil in India. We go for dexmedetomidine. On Rakesh will agree with me, and Dr. Anand also will agree with me, that most of us go for dexmedetomidine. So it is also a great drug because it doesn't suppress the respiration so much. And
yeah, very interesting session. I have 5 cases lined up, and depending upon the amount of time and the responses that you give me, I'll try to cover all 5 of them if it's possible.
I hope somebody was using dual platform. Yes.
Okay.
Now it's okay.
Yeah. So when do you decide to add in a sedation, and do you use dexmedetomidine, or you still are a proponent of remifentanil?
Yes, sedation is something we had a lot of discussion on when we were writing the guidelines. First thing to say is that you can do an awake intubation with zero sedation, and sedation should never substitute good topicalization. So for me, the most important factor for succeeding in the awake intubation is very good, very thorough topicalization of the airway. It's like when you're doing a regional anesthesia. If you do a good interscalene block, you're more likely to get a shoulder surgery, or good auxiliary block, you're more likely to get hand surgery successfully. You don't need any sedation if you do your topicalization thoroughly and very well. That's the first thing. Second thing is why do you need to give sedation? So you need to give sedation to relieve anxiolysis, to make the patient more comfortable, a bit of amnesia, maybe suppress the airway reflexes. These are all reasons for giving sedation. It's just to facilitate your awake intubation, which is primarily down to your topicalization. The reason why we recommended remifentanil is because at the time of writing the guidelines, and even now, dexmedetomidine is not used as widely in the UK as it is in India and in the States. In the States, is again very popular. And if you look at the evidence, dexmedetomidine has good evidence for successful awake intubations, as does remifentanil. It's a drug that we're familiar with in the UK, and that's why we went for a single agent, which is remifentanil. If you want to add a second agent, then you can add some midazolam. If you're familiar with dexmedetomidine, then absolutely use dexmedetomidine as an adjunct to your topicalization. But what you have to be wary of is that the commonest complication of any awake intubation is oversedation. And as a result of oversedation is an unresponsive patient, is an apneic patient, or is a loss of airway. And so sedation has to be managed very, very carefully. As I said, you can do it without any sedation at all. But if you are going to give sedation, use an agent you're very familiar with, you know how to control well, and don't over sedate. That's the most important thing. So yes, we recommend remifentanil, but if you're familiar with dexamethasone, then absolutely, it's a very good agent, very good adjunct for awake intubations. But be wary of over sedating, because that's a big problem. You've already identified the patient is difficult, and then if you over sedate, you run into even more trouble. So just remember, sedation is there as an adjunct. It's not your primary agent for the awake intubation. The primary agent is good topicalization. That's the thing you have to be most thorough about. And I hope that answers your question.
Yeah,
Yes,
Dr.
thank you.
Imran. Yeah, as we discussed, the sedation is the most crucial thing. Yeah, as you said, you cannot deeply sedate the patient. So what is very much required is the cooperation of the patient. A good cooperative patient makes the success of awake intubation. What exactly you tell, or how do you motivate the patient? Because motivating the patient for anesthesia itself is difficult for any anesthesia, and that too motivating the patient for awake intubation in a case of difficult airway is really difficult thing. That what exactly you convince? How do you tell the real seriousness of the situation, or what some specific points that you have in motivation?
Yeah, that's a very, very good question, and very important, because if you don't have the cooperation of the patient, awake intubation is impossible. You need to have patient cooperation. So the first and most important thing is to get the confidence of the patient. So the patient needs to, actually the most important thing is getting the consent of the patient. They agree to it. I've had some patients who've said, no, I don't want to awake intubation because of what happened before. It was too horrible. You're going to stick a tube in my throat while I'm awake. I don't want you to do that. They have these preconceived ideas. So the first thing is to get the confidence of the patient, and the patient knows that you know what you're talking about, and you know how to do the procedure. The next thing is I think to share the data. So if you tell the patient that you have a difficult airway, if I put you to sleep, the chances of me failing to intubate you are higher than if I do this awake. Then they are again more likely to agree to this. And that's the fact. The fact is, if you anticipate the patient to be difficult and you feel you need to intubate this patient, if you put the patient to sleep, the risks, the complications are much higher than if you do them awake. And then when you tell them that, then they are more likely to go for an awake technique. But then you also need to explain to them that with a small amount of sedation, they will have amnesia. There's lots of topicalization. They won't feel any discomfort. You need their cooperation. The success rate is high with awake intubations compared to asleep. And using those techniques, I've never had a patient refuse an awake intubation. The closest I got was a patient with EB, epidermolysis bullosa, who was institutionalized and who just absolutely refused. I showed that patient some videos of awake intubations and patients who were interviewed after the awake intubation, and asked them what they experienced and how it was. And after seeing those videos, the patient then said, okay, I'm happy, I will go for an awake intubation. But the majority of patients will tend to agree if you share the fact that they are difficult and the chance of success is higher when you put the patient, when you do the intubation awake than asleep, then most of them will agree with you, because they know they have a difficult airway and it's justified.
Yeah, that's exactly right. That is, you need to highlight them about the depth of this situation, the advantage of awake intubation, and the advantage of the patient tolerating some amount of discomfort during the procedure. That you need to tell them that you have to tolerate and cooperate in the best interest of the airway management as well as the success of this. Now,
yeah, I'll just pick up on that point, and that's a very important point. no matter how much topicalization you use, there's one aspect of awake intubation that is always a little bit uncomfortable, and that's when you pass the tube through the nose. So no matter how much topicalization you use, as you advance the tube for the first time, it is a bit uncomfortable. So you have to warn the patient; they will feel that bit, but the rest of it is fine. And once the tube is in, they won't be able to talk. So you have to remind them of that as well. But otherwise, actually, it's not an uncomfortable procedure if you topicalize well. But reminding them that as you go through the nose, it may be a bit uncomfortable. I think you're right. It is important. Some aspects can be a little bit uncomfortable, but overall, it's not too bad.
Yeah. Now regarding airway anesthesia, poking the patient in multiple points, blocking different nerves, many a times make the patient making more uncomfortable and not able to cooperate. So what type of airway anesthesia you prefer? Do you prefer these blocks or surface anesthesia, airway nebulization, or what do you usually prefer?
So topicalization is again is the most important part of awake intubation, and there's two aspects to it. There's when we wrote the guidelines, we wanted anesthetists to be doing more awake intubations, not less. So we recommended techniques that were very simple, that were very straightforward, that anybody could do. We didn't want to give techniques that were complicated and that will make people less likely to do an awake intubation when they felt like they needed to do one. But the other aspect is it has to work. It has to be a good technique so the patient feels comfortable. And so we looked at the evidence, we looked at what was published, and there are various techniques. You've already mentioned nerve blocks. Nerve blocks work very well, but not many of us can do airway blocks. And it's actually uncomfortable for the patient, and there's a higher risk profile. You're more likely to get intravascular or intravenous, intra-arterial or intravascular infiltration of local anesthetic. If you're good at them and you do them regularly, then by all means do a nerve block. But actually, the majority of people do not know how to do airway blocks. First of all, so if I recommended that you should do an airway block for every awake intubation, the rate will drop even more because most of us can't do them. But the success rate isn't that much better than using a topicalization technique. And therefore, what we recommend is using a topicalization technique because it's easier to do. It's more likely that you will choose that technique if you've never done it before, and it works as well as any other technique for the patient. So from the patient perspective, it's good, and from the anesthetic perspective, it's good. And in terms of what technique we recommend, if you're for the nasopharynx, there's two options really. There's Moffat's or cocaine, or there's cofenicane spray. Both are as effective as each other, but the complication risk and the safety profile using cofenicane spray is better than using Moffat's. And therefore, we recommended using cofenicane spray because the efficacy is the same, but the complications are less. So for the nasopharynx, you need vasoconstrictor and topicalization, and that's why we recommend cofenicane spray. And for the oropharynx and for the rest of the airway, we recommend 10% lidocaine spray. Just spray, very simple. You can spray the oropharynx, and then you can use a mucosal atomizer and spray the glottis as well. And because it's 10%, it's very potent. It works very quickly. I've done it on myself. And you only need a few sprays and you will get good topicalization. And it's simple, you just spray. And that's why, for those reasons, we recommend using a lidocaine spray because it's easier to use and it's very effective. And it works for the anesthetist as well as for the patients. So that's my long-winded answer to your question.
Dr. Imran, so have you moved away from using MADJET devices?
So we use the spray for the oropharynx, but the MAD devices, which is the mucosal atomizer device, we use that for either for the nasopharynx or for the oropharynx. So yes, we still use the magic devices or MADs, but it's a spraying device. You can also use a cannula and spray with oxygen running through the cannula.
You can see.
Spray from the bottle. There's all sorts of things. As long as you aerosol generate. The smaller the droplets, the better. It doesn't matter what technique you use. But the topicalization technique, I think, is certainly better. I also get asked about using nebulizers for topicalization. So you put some 4% lidocaine in 5 mils into a nebulizer, and again that works very well. It takes longer, so you need to for 10 or 15 minutes. But you can't get the vasoconstrictions. It's good for topicalizing the airway, but it's not good for vasoconstrictions because you haven't got adrenaline in there. But using a nebulizer, it works as well, but it takes longer, which is why I prefer to use the direct spray.
We don't have cofnicaine and the cocaine local anesthetic mixture in India. So we either go for oxymetazoline or phenylephrine for vasoconstriction separately, followed by the lignocaine for topicalization. The second question I wanted to ask is, like if you have a patent airway, you can spray and you can manage to reach the subglottis. So if you have a glottic cancer or some kind of a glottic or a immediate subglottic pathology, then you will struggle to reliably get the local topicalization in the subglottis. And the moment you enter the trachea or reach the carina, then it can produce a lot of cough. So in those kind of cases, will you put in a transtracheal block?
Yeah, again, a very good question, and that's it highlights the importance of knowing the pathology. So if you know the pathology, you will know that actually, if I try and spray the glottis, I may be able to topicalize the upper airway, but I won't be able to topicalize the lower airway because the tumor is in the way. So the techniques you can use there are you can either try a nebulized technique. Again, you know they have an airway, and if they're awake and they're sitting up, you're more likely to get to the glottis. The other option you can do is you can do spray as you go technique. So you topicalize the upper airway, you pass your fibroscope over the glottis, past the tumor, then you spray some local anesthetic over the glottis. That's how I grew up on that technique with Mansukhh Popat. I don't use that routinely because I don't need to, but sometimes I have used that if there's a tumor in the way. And thirdly, as you mentioned, there's a crocodile puncture, and you can apply some local anesthetic distal to the glottis, but when the patient coughs, it topicalizes very well. There's advantages and disadvantages to that technique. The advantage is that it actually works very well. It gives you practice to identify the crocodile membrane and actually needle it. The disadvantages are that if I said to you for the first time that you need to do an awake intubation and you need to do a crocodile puncture, you're probably going to think, you know what, I'll put the patient to sleep instead. You know, something you don't do, if you're not familiar with and you don't do regularly, you're less likely to do. But also, it can also maybe induce laryngospasm in the patient if the patient is sensitive because you're puncturing the needle, and it can be a little bit uncomfortable. So there are pros and cons to doing that technique, but knowing the pathology, knowing where the problem is, knowing will I be able to get local anesthetic to my area that I'm interested in, and if you can't, then you need to modify your technique. And so I have done spray as you go technique. I have done a crocodile puncture, depending on where the pathology is. But actually, most of the time, when I spray with my primary 10% lidocaine spray using the mucosal atomizer, I'm able to get to the area that I'm interested in. But in small number of cases, I have struggled and I have had to go spray as you go technique.
Yeah, now in between the procedures, suddenly if the patient becomes uncooperative, so you have a situation wherein you already have given much doses of local anesthetic, you can't give further doses because you don't want to give toxic dose, or on the other side, you can't deeply sedate the patient. So you little by little you give propofol, and then you are worried whether your depth of sedation is too much. Or now, what we need to do at this situation, whether to abandon the procedure, or how do you manage when you can't proceed with the procedure?
Yeah, so we looked at, we call them procedural complications. So in the paper, we looked at all the commonest reported procedural complications during awake intubation. And they can be broadly categorized into 4 groups, into oxygenation, i.e. patient becomes hypoxic, for example, topicalization, so as you described that the patient is not topicalized appropriately, sedation. Let's say oxygenation, topicalization, sedation, and the actual performance of the awake intubation. So, for example, railroading the tube or not being able to visualize properly because of secretions or blood. So if you have those 4 categories, oxygenation, topicalization, sedation, performance, we gave them the acronym STOP. Okay, so sedation, topicalization, oxygenation, and performance. They cover the majority of procedural complications. So when you get a complication during an awake intubation, the whole beauty of an awake intubation is you can think and you have time to adjust. Why am I having problems here? Have I given too much sedation? Have I not given enough sedation? Have I not topicalized properly? Is my oxygen running out? Is the oxygen getting to where I need to get to? Is it topicalization, as we heard with the previous question? Have I topicalized appropriately? So think about why you're struggling, and then do something to adjust that problem. So you earlier suggested in your question that the patient becomes uncooperative. Why is this patient becoming uncooperative? Is it because they're becoming hypoxic? Is it because I've not given enough sedation? Is it because I'm not giving enough topicalization? Think about the reason of why the patient is uncooperative and address that problem. And by using the STOP acronym, that allows me to think very quickly, make an adjustment, and then try the awake intubation. The beauty of doing this awake is that you have a breathing patient who you can stop and you can think and you can make an adjustment. The problem with that same patient when they're asleep is you're dependent on oxygenating the patient by face mask, via supraglottic airway. You've committed to the patient being apneic, and that's why we would recommend do them awake. It gives you time, it's safer, your complication risks are much lower. And so it all ties in with the whole reason of doing an awake intubation. So it gives you more time to think, address the problem, make a change, and then try again. Not more than 3 times. If you're on your 3rd attempt, you then either stop, stop the sedation and start again, or wait for some help to come. But you're able to do that because the patient is technically awake, and that's why it's safer. I hope that answers your question.
Yes, definitely. Yeah, one more thing that I wanted to ask is now the ketamine, the drug ketamine is coming back once again in different roles, especially the sub-anesthetic dose or the analgesic dose of ketamine. So considering that, is there any role for ketamine here, especially the sub-anesthetic dose of ketamine, because it maintains the reflexes to some extent? Or is it you think it is still riskier to administer ketamine at all?
Yeah, again, it depends on your experience. If you are very experienced in using a sub-anesthetic dose of ketamine and you won't oversedate the patient, then I would say actually, then in your hands, it's probably safer than giving dexmedetomidine, where you need to give a bolus and then maintain it, and you may oversedate the patient. The problem with the ketamine is that it causes a lot of airway secretions, and it can make your visualization a little bit more difficult. And obviously, there's the emergence issue as well. But it actually, there are papers where ketamine has been used. You're less likely to cause oversedation, which is good. But your airway conditions aren't quite as good as with some of the other drugs. But if you're good at giving it, and I've used sedation ketamine twice in my career. It's not a drug I would use for an awake intubation. But if you're familiar with it and you use it a lot, and you're confident that you won't oversedate, then absolutely you can use ketamine if that's what you want to use. But in terms of, if I could compare it to other drugs, I had options of other drugs personally, and the data suggests you use other drugs ahead of ketamine because they provide you with better conditions and better outcomes.
Dr. Imran.
Now regarding awake intubation and retrograde intubation, type of awake intubation. See, there are many senior anesthesiologists who are well versed with awake intubation as well as retrograde intubation. But now, because we have fiber optic bronchoscopes everywhere, even the chances of training our residents regarding retrograde intubation itself is gone. The problem is when suddenly our fiber optic scope goes out of order, so we are totally tied up. So do you think still there is a scope for teaching and learning techniques like retrograde intubation in managing this type of cases?
Yes, it's gone out of fashion, retrograde intubations. But I remember my first difficult airway case I ever did. I did a retrograde intubation. Lots of steps involved. You have to know the equipment. You have to know about the wire. You have to know how to feed it up, and then how to railroad it. And you know, it's not as straightforward as you think. And that's partly why it's gone out of fashion, because it's difficult to train and maintain that skill. Again, I would say if it's a technique that you're familiar with and you're trained on, then it does work. But teaching it, I think, is important on mannequins, getting used to the different stages involved, getting used to the kit involved. But it's a blind technique. So personally, I would say that if we can avoid a blind technique in a difficult airway situation, then you can, and then you should. But patients who are bleeding a lot and where you may not properly, you know, the retrograde technique has been used, and Barry Maguire and Michael Christensen talk a lot about the retrograde technique in the bleeding airway. So occasionally you have no other choice; you can't see anything anyway. But I think you really do need to practice it to make it work successfully, because it's not as straightforward as you think.
Can I add one thing, Dr. Imran?
Yes.
Raj. Yeah. So we have done a few cases of retrograde where you use a urology glide wire instead of a catheter. And once the glide wire comes, you take it through the suction channel of the fiber optic bronchoscope. So then it doesn't become totally blind. So, and that will, and once you are sure that the fiber optic is beyond the lesion and it's come into the trachea, you can pull out the wire, and that will work as a beautiful conduit also. That is one suggestion. I have one more question for you. So if you are dealing with a critically narrow airway and say it's like 4 millimeter and your fibroscope is also like 3.8 or 4, and you're planning an awake tracheal, so you are worried about a cork in the bottle. So how do you prepare for that?
Okay, I'll just go to your first point, which was about retrograde using the scope. And the important thing there is knowing your equipment. So knowing the wire will fit through the working channel of the scope. So if you don't practice it and you're not familiar with the kit, then it won't work. So yes, it's a good way of making it a visualized technique as opposed to a blind technique. But you need to know your equipment, and that's why you need to practice it beforehand. So critical airway stenosis, I get asked this a lot. A cork in a bottle, never seen it, because the airway is dynamic, and if the patient is breathing spontaneously and they're able to take a big breath, then actually, if they can breathe, that means there's an airway, there's a hole, and actually, you can still breathe around a fibroscope. The airway you're talking about, if it's 4 millimeters,
absolutely. We were not really concerned about the hemodynamics in this patient, and also
and reflex would have been maintained better with ketamine than with.
No, so I was a little.
There we go. So the stenosis is so narrow that you're worried about a fibroscope occluding, then you've got no chance of railroading a tube. So that's why in those situations you'd have to go subglottic. You have to bypass the upper airway, and sometimes you can't intubate them at all. So you have to use either supraglottic airway, positive pressure ventilation, or Thrive. These patients you're going to be either operating on them, lasering them, dilating them. There's different types of surgery. If you want to manage the airway and you want to ventilate them, then you're going to have to go subglottic. So again, knowing the pathology, knowing the level of the pathology is really important. But I've never seen the cork in a bottle effect, because the airway is dynamic with a fibroscope. and therefore, you always be able to breathe around it. Yes, it will be a little bit more difficult, but if it's that narrow, you won't be able to get a tube in anyway. So doing a fiber optic intubation is pointless because you can't get the tube through such a narrow stenosis. So you might have to think of other ways of oxygenating the patient.
Yeah, thank you. I just wanted to say that it's not an absolute answer for all your solution, and that sometimes you may have to go subglottic also.
Yeah, definitely.
So I think we are just getting the time over. So may I request, because we have talked about so many important points about the awake tracheal intubation. With your experience of awake tracheal intubation, can you just summarize what would be the triggers where you will say it's a failure of awake tracheal intubation and we should go for surgical access or some other technique? So with your experience, those triggers that we should keep in our experience of clinical practice.
Yeah, so there are certain conditions where an awake intubation is not appropriate. If the patient is uncooperative, if there's lots and lots of bleeding, if the patient refuses, in these situations, you really should consider not doing the awake intubation. Also, knowing where the pathology is. If the pathology is as such that it's so narrow that you will not be able to intubate this patient, there's no point going for an airway from above. You might have to bypass this. So there are certain conditions where you would bypass the upper airway, you go straight for a front of neck access, and either under local or even under a general anesthetic. So understanding the pathology, understanding whether the patient will allow you to do an awake intubation and the conditions are right for an awake intubation will then make you decide whether to go upper airway or bypass it and then go for a front of neck airway.
Absolutely. I think I think almost 45 minutes passed away as if wonderful. I think so many important messages from Dr. Imran. I think we were firing you with the questions and you with a lot of patience, with loads of experience and knowledge. You gave us so many key points and carry home message. I think is indeed a learning experience for us. And I'm sure the delegates who are listening to us must have been more wiser for taking this technique forward. So sincere thanks to you, along with my co-chair, Dr. Anand Bangera, for sparing the time and asking you to speak non-stop for almost last 45 minutes, getting all the flavor of your vast experience into this field. And I'm glad to have you here. Thank you so much, and over to organizers for the last words.
Thank you, Dr. Imran, and thank you, Dr. Rakesh, and all the delegates who have taken use of this. Thanks.
Thank you. Thank you.
Thank you, everyone. Thank you.
Dr. Imran. Yeah, Dr. Imran.
Which is that the paper we publish is open access, is free. So if you go to the Anesthesia Journal, and you can download it for free, and everything I've said is in there and more. But you had some very, very good questions, and I was very happy to answer them. So thank you so much for having me.
So if I may ask one more last question, were there any changes in your method during the era of COVID for awake tracheal intubation?
Yeah, again, very important question. And there were lots of changes. We wanted to avoid coughing as much as possible. We wanted to make sure the patient is as well oxygenated as possible. So we were using a high flow oxygen. We were using a bit more remifentanil because it suppressed the coughing reflex. And we were wearing PPE. So communication is a lot more difficult. Not only amongst your team, but with the patient. The patient can't really hear you properly, and you need a cooperative patient when you're doing an awake intubation. And also having your plan B, your plan C, or plan D, you spend more time preparing for failure because you're probably more likely to fail because for all those reasons I explained earlier. So there are some modifications that you need to make. It is a bit more difficult, and we published the first ever awake intubation in a patient with COVID. In anesthesia reports, and again, if you read that's open access as well. You can read our experiences and what we did differently. But there are certain little things that you need to think about because it is more difficult when you're wearing full PPE to do an awake intubation in a patient. Very good question.
Okay, thank you, Dr. Imran. Thank you, Dr. Anand. Thank you, Dr. Rakesh.
Thank you. Thank you.
Thanks a lot. We'll start again at 5 o'clock for the next session. Thank you.
Thank you. Bye.
Evening. Hello. Can you hear me? Yeah. Good evening. So we are going to start this session in just a bit. We are just waiting for Dr. Tim Cook to join us. He's logged in, unfortunately, in the other hall. So we are waiting for him to join in this one. So just hold on for 5 minutes and we'll be ready to start the session.
Sure.
Okay, good evening, Professor Cook. Thank you for joining. Okay, so
hello, very nice to see you.
So good evening. So this is a Meet the Expert session. I'm Dr. J.V. Devetia from Tata Memorial Hospital, Mumbai, and I will be moderating the session along with my co-host, Dr. Malini Joshi, and who's a professor in my department, and we work together. We are colleagues. And with us, we've got Professor Tim Cook, who is a renowned expert in the field of airway management, anesthetics, as well as intensive care. He works at the Royal United Hospital in Bath. And we've all heard of him first, I think, with the NAP4 study, and he's been associated with a number of NAP National Audit projects. And he's very much involved in preventing mistakes and errors during anesthesia and how to improve outcomes with airway management. And he will be speaking to us on something which appears to be very straightforward, but something which can be a disaster if we don't pick it up. And so he will be with us and speaking to us about the missed esophageal intubation. So Professor Cook, welcome and thank you for joining. I know you've had a busy day and it's been a struggle to join us. So thank you for joining. So you want to?
Yep. So I think I'm not on mute, am I? No. So apologies. Firstly, in as much as I was unable to, I'm on our COVID intensive care today. So I was unfortunately unable to join the session at the end of my aerosol talk earlier today. So apologies for that. And I'm not planning really to give a talk with slides about esophageal intubation. I was hoping we'd just have a conversation about it. I think if some information comes up during the conversation, I'm happy to share some slides. But I thought we'd probably start with the conversation. And the context of it is for us in the UK. So people will remember we had I hope will remember, some people won't. We had the 4th National Audit Project on airway management about 10 years ago. And we had about 180 cases. There were 140 from anesthesia. And I had expected 10 years ago that there would be no cases of esophageal intubation. There were in fact 9 cases of esophageal intubation, 4 in the intensive care, 3 in anesthesia and 2 in the emergency department. We probably didn't capture all of them. And of those 9 patients, 7 of them died and 2 of them suffered permanent brain injury. So all were significantly harmed. And esophageal intubation, I think, remains a bit of a blight. So we made various recommendations. One of the key emphasis, or one of the key areas of emphasis in NAP4 was the use of capnography. Essentially, the use of capnography everywhere for airway management. I don't rely now on clinical signs for confirmation that a tracheal tube is in the right place or that I'm ventilating the lungs. I rely on monitoring. So I rely on capnography in the first instance. I will also rely on spirometry or pressure waves and oximetry. But in terms of confirming that I've ventilated a patient on intensive care or in the emergency department, or that when I go into somebody else's operating room or critical care, the first thing I'll look at if there's any concerns about the airway is probably the capnograph. And while a capnograph is not a panacea in terms of airway management, it does provide great usefulness as a first step. And in the last 3 years, our coroners have reported, I think, 12 cases of deaths to our college, which were areas where the coroners felt that they should be asking the college to make changes to improve patient safety in general. 7 of those 12 cases were about the airway. So of all aspects of anesthesia and intensive care, 7 of the 12 were about the airway, and 3 of those in the last 4 years were about missed esophageal intubation. And those 3 cases led to 3 fatalities. In my view, they were all avoidable. And 2 during elective surgery and 1 during an appendicectomy led to fatalities of previously healthy patients. I think there are more events than we've been told. I think they do occur, and I try and identify these cases when they occur elsewhere, and they probably occur in most countries. And I suspect there are deaths that are recorded as anaphylaxis or recorded as airway obstruction, which are actually missed esophageal intubations. 3 years ago, we set out one of the misunderstandings is that, so a default position that I take is that if the capnograph is flat after you've intubated, that you must exclude esophageal intubation. There are other causes of a capnograph being flat, and probably people on the call could give me 10 different causes of a capnograph being flat, which are not esophageal intubation. But if you don't detect esophageal intubation rapidly and remedy it, then the situation will become a profound crisis. People's thinking processes, their behavior, their interaction with others will deteriorate, and a genuine crisis will occur. And a missed esophageal intubation can rapidly become fatal or lead to significant brain damage. So I think as a routine, that the first message in this discussion is that if the capnograph is flat, whenever the patient is intubated, including during cardiac arrest, which you might pick me up on, if the capnograph is flat, then the next step is to exclude esophageal intubation.
So Tim, let me just pick up a bit here. So, we are a sort of, in our part of the world, not everyone gets a capnograph to confirm tracheal placement of the endotracheal. Yep. What you are saying is that even with a capnograph in place, you are missing esophageal intubations. And that is because of incorrect interpretation of flat capnograph waveform trace.
Well, I think, so at the moment, so in the UK, we're going through a process, it's a rather painful process of trying to once again look at in the aftermath of another avoidable fatality from esophageal intubation. And we're trying to work out what we can do better to reduce the chance of it occurring again and another patient having an avoidable death. And one of the things the college has done is to emphasize what we call the no trace, wrong place message. And so if there's no trace on the capnograph, you're in the wrong place until you've proven otherwise. You might be in the right place, but you're most likely to be in the wrong place. And there are numerous cases from other countries, I should say. And then, so I lost my train of thought. So that's the first step. Sorry, Jiggy, just remind me what the question was. I lost my train of thought.
So my question was, we've always assumed, because we are not in a universal capnograph country, that the capnography will prevent diagnosis of missing out on esophageal intubation. But it also appears that even with a capnograph in place, it is possible that a flat capnograph trace can be misinterpreted. And in spite of having a flat trace, you could still miss an esophageal intubation.
Yeah, so if you don't look at it, if you intubate and the intubation was a bit awkward and you're distracted by something and it's a critically ill patient and they're now hypotensive or they've even had an arrest, you may not look at the capnograph. So if you don't look at it, you won't see it. In the UK, there'll usually be 2 people intubating at the same time. And one of the suggestions we've had is that after each intubation, there's a 2-person verbal check that capnography is in place, that there is a trace. And the benefits of that are that if there are 2 people, it's less likely that you won't look at it at all. And one would hope that the 2 individuals will be able to confirm together that there is a capnograph trace. There are some issues around hierarchy and someone just confirming automatically what somebody more senior to them says. But I think it'll make it less likely that the capnograph won't get looked at and less likely that someone will completely ignore a flat capnograph. The second element, so in the most recent case that happened last year, the coroner's court heard that capnographs were in use throughout the hospital, but not all the monitors had the capnographs displayed. In some of them, you had to go into the menu and bring up the capnograph so that it was automatically displayed. And that in different parts of the hospital, the different monitoring graphs, as it were, so the oximetry, the capnograph, airway pressure, had different colors and were in different orders. And one individual came into the anesthetic room and when this crisis was going on, glanced at the monitor and saw the airway pressure trace and thought that was the capnograph. So they mistook the airway pressure trace, which can also look like a square wave, as the capnograph. And so that's another sort of human factors failing. So you have to, in that hospital, you have to turn on actually bring up capnography for it to appear on the monitor. So that might be omitted. You might forget that. If it is there, it may be a different color or in a different order on different monitors in that hospital. And that's probably true across many hospitals in many countries. And so you could misinterpret things. And so there is we are trying to work through how best to standardize what capnography looks like on a monitor. What I would favor is that it's white, that it's a white trace and that the underside of it is filled in. So you'll sort of look at the area under the curve. And so that you'll have a white and gray filled in capnograph, which looks distinctly different from anything else. And that's what I would favor. So I think there's not looking at it, there's mistaking it for something else. There's not understanding the implications of it. And I think anaesthetists in the UK 10 years ago were not particularly familiar with the fact that if you are in cardiac arrest and your capnograph and you're intubated, then your capnograph should still be positive. It'll be an attenuated trace, but it will still be positive. I can show a slide on that if you want me to. I can, if I can just.
I think it's important to just know that, we all think that in the capnograph, the trace will be completely flat, but I guess what you're saying is if there are effective chest compressions and there's ventilation going on, you might get an attenuated capnograph trace.
You would expect to. So this is Glenda Logsdale. This is the lady who died during appendectomy. And you can see here that we have a capnograph trace, and we've also got an airway pressure trace. This is from a routine anesthetic, and they look really quite similar. And if the lower trace was absent, was flat, it's not inconceivable that coming into somebody else's crisis or in your crisis, you could mistake that for a capnograph trace. And if we slide down, here we have what we say in the UK: no trace, wrong place. and you have to have a normal capnograph trace. But this is a trace from a cardiac arrest. So this is 4 kilopascals. So what's that? 28, 30 millimeters of mercury of CO2 if people use millimeters of mercury. But actually the trace is at about 2. And you might see it at 1 kilopascal or 7 millimeters of mercury. So, and with it increasing with ROSC. So during a cardiac arrest, there will be an attenuated trace, even in the absence, even though the patient's in cardiac arrest. The next question, of course, is people say, well, is that dependent on CPR? And I don't think there are extensive studies, but what there are is several studies where, so I think if somebody comes in cardiac arrest and they're intubated, it's likely that CPR is going to be ongoing. And so you will see that trace. But if you stop CPR and continue to ventilate, which is an unusual circumstance, you should still see some CO2. And there's several studies which were done by Cliff Reed and team, who's an emergency physician in Sydney. And they took cadavers from the fridge, I think a couple of hours after death, and ventilated the patient's lungs. They didn't do chest compressions, but they ventilated the patient's lungs. And in every patient, they had CO2 coming out. So there are circumstances in cardiac arrest if someone's been arrested for a very long period of time, or if the major blood vessels or the major bronchi are disrupted, you won't get CO2. But the expectation, even in cardiac arrest, would be that you will see an attenuated CO2. And if it's completely flat, as we have on the right, that should prompt you to exclude esophageal intubation. So I think we've got 3 reasons why, in spite of using capnography, you might end up with an undetected esophageal intubation. One is that you don't look at it, or you've not put it on the screen. Second is that you mistake something else for it. And third is that you misinterpret it because of the circumstances. And of course, if we do, so these 3 cases that we've had in the last 2 years in the UK, those were cases where the patient was intubated. And of course, they rapidly progressed to, there were 2 of the patients were heavy, and they rapidly progressed to hypoxia and then to a hypoxic cardiac arrest. And if you are not if you're not aware that there should still be a trace in spite of cardiac arrest, then it's easy to interpret it as no trace because they're in cardiac arrest, which is wrong. And I think the other mistake that people often make is they say this is bronchospasm. So you put the tube in, it's difficult to ventilate, and there's no CO2, and a misdiagnosis of bronchospasm or anaphylaxis is made. And that was the case in the Glenda Logsdale case, the most recent case, where they went down the route of saying this is anaphylaxis, and other people came in, they said this is anaphylaxis. And actually, if someone had said, look, there's actually 0 trace on the capnograph, then I think that her life may have been saved.
Malini, any comments?
Dr. Cook, so in the event when the capnographs are not available, so what do we do in such a situation? How do we recognize missed esophageal intubation?
Okay, so I'm going to take it back, and I'm going to say, why isn't the capnograph available? Because so when we did NAP4, capnography was used in less than 50% of hospitals in the intensive cares in the UK, and I think it was about 25% of intubations, and it was used in most intubations in the operating theatres, but not all of them. And we recommended, without evidence from a randomized controlled trial or a large cohort study, that capnography should be used for every intubation everywhere. And there was a huge amount of resistance. Some of the senior intensive care organizations were reluctant. They didn't feel that NAP4 provided enough evidence, that it needed an appropriate trial. My answer is you'll never do a trial that will illustrate this or provide further information. And slowly, and then we've just opened a new ITU. We haven't got capnography. We can't introduce it. Our systems don't work with it. It's too difficult. It's too expensive. We're still having the same discussions with neonatologists and so the neonatal intensive care groups. But over time, there became an acceptance that this was a safety issue. And actually, I don't think many people, if any people, would now go back to intubating, and not just intubating, but monitoring the airway after intubation without capnography. So the first question when you say is, what if we don't have capnography, is why don't you have capnography? And accepting that you don't have capnography, I think, is the first misstep. And there are, so we can deliver capnography in my hospital in anesthesia, in intensive care, in the emergency department, on the wards, in the neonatal unit. So you can have an expensive waveform, a relatively expensive waveform capnograph. They're not that expensive. You can have a capnometer, as is used in pediatrics, with a color change. I'm not particularly in favor of these, but you can use capnometry, where you get a color change, and the color change is supposed to give also a rough indication of the actual concentration. Not my favorite. And there are portable side stream sampling capnographs as well. So the first question is, if you're not delivering care in a very remote, underfunded site, why aren't you using capnography? And is that a failure of your system? And in many cases, I think it will be. So I think the first step needs to be to say, we will use capnography and we'll make sure it's a standard of care. And in the UK, it's a standard of care. And many people adopt those guidelines. So that's a long way of saying, I think capnography, it's a weak excuse often to say, we didn't have capnography. Why didn't you have it?
You're right. It's not a reason, it's an excuse. And it's not just a system problem, it may even be a mindset problem, that it's too expensive. But I think it's a point well taken. When we made our guidelines, the All India Difficult Airway Guidelines for tracheal intubation, we actually put it in there that you must confirm intubation with capnography. There were lots of protests. People said, oh, but so many people don't have a capnography. I said, well, get one in the next, set a target in the next 2 years, next 5 years, whatever. You'll make sure that all your hospitals have capnographs. So the problem with the ICUs, we just did a study called the INDICAP study, looking at intensive care practices, and only 35% of ICUs routinely use capnography to confirm tracheal intubation in the ICU. So it's work in progress. I'm sure it'll happen. But
yeah, in NAP4, if you had an event that met the inclusion criteria for NAP4, and those inclusion criteria were an airway complication that led to death, brain damage, ITU admission, prolongation of ITU stay, or front of neck airway, then if you had one of those events in anesthesia, then your chance of dying was 14%, 1-4. And if you had one of those in critical care, where they were about 50 times more common, your chance of dying was about 60%. And of the events that occurred in critical care, we judged that 70% of them were contributed to by the absence of capnography. And it's not usually, then they weren't usually intubations, they were displaced tracheal tubes, blocked tracheal tubes, other airway problems, accidental extubations in a difficult airway, a few failed intubations. But then, of course, they all cycle to a missed intubation, and three of the deaths were esophageal intubations, and they were disproportionately highly represented in ITU. So I think ITU is a place of airway danger, and because the patients are sick, when we had the same discussion in the UK about capnography, someone said, and he was a senior individual in a senior organization in ITU, he said, if someone dies during elective anesthesia from an airway problem, then it's like a guardsman who's just doing guards duty at home, and they die, and it's a tragedy. But if someone dies of an airway event in intensive care, it's more like that guardsman being deployed and dying in war. which I thought was an odd comparison. If the deaths are avoidable, which they are in both those circumstances, whether it's at war or in the sort of marching area, then I think those are both. I think they're both equally disastrous. So I thought it was an odd thing to say, and as Jiggy says, it's a bit of a mindset. But coming back, I'll go on and on about that. I think coming back to it, that there may be circumstances where capnography is not in use, and I think people have to accept that they're in a very difficult situation then. So as long ago as back in 1990, when the ASA closed claims group reported on airway complications, they identified quite a lot of deaths and brain damage from esophageal intubation. And their comment was that I think in 70% of cases, the tube position had been confirmed by clinically before things happened. So people had looked at the chest going up and down. They'd looked at misting in the tube. They'd listened to the chest. They were auscultated. And I think there's a huge amount of bias, confirmation bias. You hear and see what you expect to see. And when the ILCOR, International Liaison Committee on Resuscitation, have looked at the sensitivity and specificity of clinical tests compared to capnography for confirming esophageal or tracheal intubation, then the sensitivity and specificity of the clinical tests is low, and it's extraordinarily high for both sensitivity and specificity for capnography. So ability to detect tracheal or esophageal intubation and distinguish between the two. So I think if you're not using it, you have to accept that your sort of threshold for concern has to be very high. So I wouldn't say one shouldn't examine, but I think one needs to accept that those examinations are very limited, and particularly in obesity. So often airway difficulty occurs in obesity. Then clinical auscultation, very much dependent on the size of the patient, the quality of the ventilation, the quality of the stethoscope, the environment that you're in. Noisy resuscitation environments can be very difficult to hear and see things properly. And so it can be very difficult. A simple message that if there is uncertainty as to whether the tube's in the right place, then relaryngoscopy to see what you can see, ideally with a video laryngoscope. But I think, there's that question, if you've got sufficient money to be buying video laryngoscopes, shouldn't you have capnography? And I think, I'm a massive fan of video laryngoscopy. We only use video laryngoscopes in our hospital. We're not a posh or a particularly affluent hospital, but we only use those. But if I was to choose between video laryngoscopy and capnography, I would have capnography first, and then video laryngoscopy. But if you don't have capnography, your clinical examination needs to be very careful and suspicious. Can I hear this? Can I really hear it? Is the chest really moving, or is that the stomach moving and pushing the chest up? And suspicious. And if there is any suspicion, the default should be to relaryngoscope, and people will use the term, if in doubt, take it out. And that's easy to say, but if it's an elective case, straightforward, low risk case, and laryngoscopy appeared difficult, then I think it's completely reasonable to take it out and put it back in again, or put a supraglottic airway in. But if it's a difficult patient or a patient on critical care who's complicated, and there are maybe significant implications to taking it out, then I think it becomes more complicated. And I think in those circumstances, video laryngoscopy, ideally with a separate screen so that two people can see and confirm what's visible, or flexible bronchoscopy down the tube are options. People use these sort of self-made esophageal detectors, which are either a 50 ml bladder syringe attached to a catheter mount, or the sort of bulb of a turkey baster. And they rely on the fact that the esophagus will collapse and the trachea shouldn't. And so you can pull out air, and if air comes out when you're attached to the tracheal tube, it's supposedly in the trachea, not in the esophagus. And if it's in the esophagus, it'll collapse and you won't be able to pull air out. The same with the bulb. But those are not reliable. And the days of using those, except in extraordinary circumstances where capnography is absolutely not available, I think it should be few and far between.
So Tim, that just brings us, and you partially answered that question, is, you said if there's no trace, you should exclude esophageal intubation. So how would you do not? Many of the intubations, esophageal intubations happen even in a otherwise simple laryngoscopy and intubation. It's at the end, the person will tell you, I can't believe my tube was in the esophagus, So how do you, so if you can do a repeat video laryngoscopy, even a direct laryngoscopy, you'll see the tube in the esophagus. But if it was difficult, if your tube went in the esophagus because laryngoscopy and intubation were difficult in the first place, how would you reconfirm that it's in or not in?
So I may be slightly missing the question, but I'm just going to go to these slides and can you see that slide?
Not yet.
Okay, let's just see. Can you see it now?
Yeah, got it.
Yeah, okay. So if we think about human factors, then the most effective human factors for avoiding, so what we'd like to do is we'd like to avoid putting the tube in the wrong place in the first place. Rather than detecting that we've put it in the wrong place. So it's a much more efficient and safer system design to avoid esophageal intubation rather than detect it and correct it. So I think there are a number of things that can be done to minimize the chance of esophageal intubation. So if I've looked at quite a lot of studies, so a whole series of cohort studies or randomized controlled trials, whether it's Stiletto, Bougie, de Jong's papers on critical care intubation, et cetera, and there's somewhere between 2 and 4%, and I've seen 19% rates for esophageal intubation, and most of those will be detected. But if you miss 1% of your esophageal intubations, then that means that's about 1 in 500. Sorry, 1 in 5,000 cases. So many hospitals would then have a missed esophageal intubation each year. I think we can improve circumstances by better airway training, by education about capnography, about education airway management. I think we can get away from the idea that the intubator is the only person managing the airway and accept that the team can offer help and many of the assistants, if you have assistants working in theatres or intensive care, may be more experienced than actually the intubator. But also video laryngoscopy has an important role, and it has an important role in preventing or reducing the incidence of esophageal intubation, but also these other factors that are listed here. It makes tracheal intubation easier. It makes it easier for others in the room to identify problems. It reduces difficult views and makes easy views more common. And if you are skilled in it, if you're trained in it, then whether you use a Macintosh or a hyperangulated blade, it should increase first pass success and reduce failed intubations. I've already made those comments about monitoring. So this is the updated Cochrane review, which is not yet published, but is soon to be submitted. And in it, we decided to look at the rate of esophageal intubation. And so it's Jan Hansel and Andy Rogers who've done the bulk of the work. And this is, I think, 40 studies where we were able to extract the frequency of esophageal intubation. So this is most of these will be detected, but you roughly half the incidence of esophageal intubation if you use a video laryngoscope. It's statistically significantly different. The groups are different. So using any video laryngoscope, overall, you'll reduce your chance of esophageal intubation and therefore logically of undetected esophageal intubation. Depending on how you analyze it, you can look at whether Macintosh, so if you use I won't go into too much detail, but if you use different types of analysis, you may get significant or not significant results. But essentially, with a Macintosh video laryngoscope, you probably reduce the incidence by slightly less than half. With a channeled video laryngoscope like an Air Track or a Pentax AWS or the newer Ambu scope, again, you reduce it by about 50%. And if you use a hyperangulated blade, you reduce soft intubation by about threefold. So these are very major differences. If you do the statistics slightly differently, they're not statistically significant. But it makes no sense to me to say if you do the statistics in one way, you reduce the soft intubation threefold, and if it's not statistically significant, it doesn't matter at all. I know which I'd want to have be used. But I think more broadly, we can improve human factors to reduce the risk of esophageal intubation by, as I say, training people, better education, understanding capnography, understanding the equipment and the techniques they're using, and including everybody in the team. Checklists are useful, and probably they're most useful for making sure that people don't forget to put the capnograph on, and to make sure that everybody understands the ABCD plan that they're going to use for intubation. Hierarchy is an important thing. I always think, I often find myself saying, I really think we work in a very flat hierarchy. And then I look at the person who I've said it to, and if they're a junior doctor or a junior nurse, they'll look at me with astonishment. And I think you can only perhaps tell how flat a hierarchy is by asking the person at the bottom of the hierarchy rather than the top, if such exists. And so I think working in teams better is better for thinking about flattening hierarchy, so that people, if they see problems. So in the 3 cases that we had in the last 10 years, in each case, well, in 2 out of 3 cases, a non-anaesthetist, one was an anaesthetic assistant, one was a surgical registrar, suggested that the tracheal tubes in the esophagus, or at least in the wrong place, and that was ignored. And then in the 3rd case, another anaesthetist briefly suggested the tubes in the esophagus, and again, it was not acted on. So we need to encourage people to speak up in crises and to be empowered to speak up in crises. And I think unless you are at the bottom of a hierarchy, you can't understand how difficult that is. So I think I may not have answered your question, Chiggy. You might have been asking a different question, but I think it's important to mention these human factors.
So yeah, so you did make an important point, but yes, you didn't answer my question. So if I didn't,
try again. Let's try again.
No, so once you see a flat trace, you say you should exclude esophageal intubation. So how would you exclude esophageal intubation, especially if your laryngoscopy or intubation were difficult in the first place?
Okay, so in my practice, I think there are 2 different circumstances. If it was a straightforward intubation, let's say I was doing an elective lap chole, a patient without predicted difficulty, and I or a colleague had intubated the patient, there was a flat trace, then I would take the tube out. I probably wouldn't even look again. If the airway had been straightforward to manage and there was not a high-risk patient, an elective patient, I would say something is not right here. Let's take the tube out and restart. If they were a difficult ENT case or a critically ill, and then you would go back to whatever you're doing. You go back to face mask ventilation, you put a supraglottic airway in, remembering, of course, that the priority here is oxygenation, not intubation. And it's really important, I think, to remember that most airway disasters do not occur in patients with difficult airways. They occur in patients with straightforward airways where they weren't managed correctly, unfortunately. And I think those are the greatest tragedies. If, however, it was a patient who was either anatomically difficult ENT case, struggled to intubate, or a physiologically difficult patient on ITU, then I would have a different approach. And I would say, look, this tube might not be in the right place. We've got to work that out. So I would probably examine. I think if you can hear clear air entry, it's unlikely because you're probably not ventilating lungs, but if you can hear clear air entry, makes you think, and you can see chest rise, it makes you think, but it's not that strong. I would certainly re-laryngoscope the patient, and in my practice, I would be doing that with a video laryngoscope with separate screen. And if I'd used a standard Macintosh to intubate video or direct, I would change to a hyperangulated blade if it was immediately available, so that I got the best view of the tube going wherever it was going and confirming it was in the right place. I would look at the pressure trace on the ventilator, and if necessary, I would fibroscope down the tube to confirm I could see tracheal rings. And that's going to take a few minutes, but I would go through that process to, if there was a tube that I really didn't want to take out, I'd go through those processes to say what additional information, if I've got auscultation, chest movement, capnography, re-video laryngoscopy, etc. How confident am I that I'm in the right place? And but I would want to exclude. I want to be very confident that the tube was seen by me and somebody else going through the cords before I moved on to saying, okay, there's another diagnosis. This flat trace is due to something else. The most profound bronchospasm, because I'm not convinced that much bronchospasm causes a flat trace.
Okay, that's great. So we've got all those things sorted out. So, and I think one more thing, if you had access to ultrasound, if you could do a quick and long slide, that would.
Yep.
Plus or minus.
Yes, that's a really good point. Yeah. So ultrasound to look at ventilation of both lungs, and also potentially to examine the neck. So I haven't spent much time looking at tracheal tubes in the wrong place. But I know someone like Michael Christensen would say that it's a very, very effective way to confirm that your tube's in the right place. Not so much that you see the tube in the right place, but if it's in the wrong place, you'll see the double circle sign. So yeah, and I've even heard people advocate that ultrasound is better than capnography. That doesn't make sense to me. As things stand.
Great. Malini? Unmute, please.
So, Dr. Cook, from what I understand from Lab 4 project and from the recent Glenda's case, is that identifying the capnogram, okay, the flat capnogram means that the endotracheal tube is not in the esophagus, and also the human factors, recognizing, so human factors such as overconfidence, confirmation bias, and fixation errors were responsible for most of this not detection of the esophagus. So what actions would you like in future to prevent such undetected esophageal intubation?
Okay, so a couple of points on that. Firstly, you're not a bad person if you intubate the esophagus. You're not a bad person, you're not a bad anaesthetist. And I think anybody can make the mistake, and we need to be humble. As Jiggy, I think, kind of suggested, the commonest thing when we were doing NAP 4, and there were these series of airway, disasters really, one of the commonest things that was said in the narratives that we got, which were relatively short, was, I couldn't believe it happened to me. I'm not the sort of person that makes these mistakes. And most airway management is routine. And so I think we need to be humble. We need to acknowledge that we all make mistakes and that it can be us. So we need to be on our mettle. We need to be aware that it can happen to us and not be, not have that confirmation bias, to maintain our situational awareness, to work in good teams who are well educated and supportive of us, so that we can optimize our skills. And the other, so my good friend Fiona Kelly, who works in the same department, who's a very experienced in human factors, she says that, so when we do mandatory airway training with our teams, with the ENT surgeons and ED physicians from time to time, but with all anaesthetists, and we've mandated it in our department, and they're mainly technically based. And one of her phrases is that good technical skills create space for good non-technical skills, or for human factors. So I think if you understand your your techniques and your skills, then that gives you headspace in a crisis. But also, if you're working in a team that's collaborative, that ideally is work together, that's not always possible. But a team where the culture is right, where there is an ability for people to speak up, to communicate, to give ideas, and where senior people are receptive to others' ideas, particularly in a crisis, then I think the chances of getting it right for the patient, and the staff are increased. So good teamwork also makes space for good human factors.
Dr. Cook, I was very curious about the PACE and the SNAPPY mnemonic which you had put. So, so PACE, prioritize, and then, so would that work, sir?
So here we've got PACE. Just going to share again. Snappy before then. Right, so we'll go with Snappy first. So Snappy, these are both, I think, unvalidated methodologies, but I quite like them. So Snappy comes from New Zealand, from Professor Weller in New Zealand. Can you see the screen again?
Yes.
Yep. So this is a paper where they introduced this, and it's a tool for in all the cases, again, these coroner's cases we had in the UK, in each of them, the coroner described the anaesthetic room or the area where the intubation was taking place as chaotic, and people panic in difficult circumstances. And if one arrives from outside, when an event is evolving, it's sometimes very difficult to know what to do. Martin Bromley says, I think the phrase he wants people to use is, "So what's been going on?" Just to stop everybody and say, "So what's been going on?" But to have a pause. And what Professor Weller says is snappy, which is you stop everybody, you get their attention. You notify the team of the problem if it's known. You make an assessment, you assess the situation, you say, this is the plan, you prioritize that plan, and then you invite ideas from the rest of the team. And while we want to have flat hierarchies where people can communicate across those different interprofessional groups, there is also a need for a team leader and for sort of leadership and followership in these circumstances. So it's a bit like a cardiac arrest situation or a trauma team situation, where in many systems people will now allocate a team leader. So this is the team leader. They don't manage the airway. They don't put the drips in. They don't start CPR. They are the team leader. They stand back and they try and have some perspective. So I think somebody coming in, if you come into a new situation, I think in your mind, I'm going to stop, notify that there is a problem or what the problem is, make a very rapid assessment, form a plan, prioritize that plan, and then ask the crowd what it's going to be. So that's one, that's snappy, unvalidated, but I think it's a reasonable thing to do. And then PACE is there are different forms. I can't remember, there's one other which is advocated in the human factors guidelines, which are coming out soon, but PACE is one I quite like. And so this is, for instance, the circumstance where a junior doctor is working with a senior, or an anaesthetic assistant is working with a doctor, and they're uncomfortable with what's going on. And rather than diving in, so it's a way of empowering the assistant to, or the person who's in the lower part of the hierarchy, to do what is right for the patient, to make things safe without embarrassing either themselves or the individual they're potentially challenging. And not everybody will agree with this. So Laura Duggan from Canada, when I put this on Twitter, she said that she thought it was hateful, but I don't happen to agree with her on this particular matter. I think it's not unreasonable. So if someone was having repeated attempts at intubation, so one of the things that people do when they are not coping in a crisis is go into their shell and keep on doing the same thing, and doing the same thing again and again and again, expecting a difficult outcome, as we know, is a form of madness, as Einstein probably didn't say. But somebody tries the same thing, be it putting in the supraglottic airway or the tracheal tube multiple times. Are you going to try and intubate again? Which they do. Then the next step is to alert them that's a problem. You know, this is your third attempt at intubation. I don't think you should be intubating for the fourth time. I'm going to stop you having another go and call somebody more senior. And you might escalate that at that pace or at a different pace. But ultimately, we have a responsibility to protect our patients. And the idea of the hierarchy where people can't challenge seniors needs to go. And if there's an issue of safety for patients. So I think it's not unreasonable. We presented this to our anaesthetic assistants in our hospital. We said you can use this. We asked for their feedback, and a couple of weeks later, one came back and said that was really useful. I used that when a trainee I thought was not behaving correctly, and that helped. The other thing I'd say is the word focus. So in our hospital, our surgeons came up with the idea. People talk about the sterile cockpit. So when you have a crisis, I had a patient who I couldn't ventilate in theatre about 3 weeks ago. I think he just had some severe laryngospasm at the beginning of an elective operation. But I was trying to face mask ventilate him and then ventilate him through a ProSeal. I was getting no CO2 out. And I was realizing there was a problem, but the nursing staff were starting to touch the patient and prepare him for surgery. Because we anaesthetised in theatre, they were, moving limbs and things. And the phrase we use in that circumstance is focus, or can we have some focus? I have a problem here. A surgeon has got a difficult time, and they want people to concentrate on what's going on and have some quiet focus. And I use the same term. We need some focus here, and that's kind of a code word for we're in a certain situation. We need to concentrate on this situation.
Okay. I'm very sorry to interrupt everyone, but I think I need to wind up the session.
We're just about to wind up. So thank you very much, Tim, for joining in despite your schedule. I'm sure you've got to go back to your COVID duties. I hope
I do.
Hard. And I hope Omicron doesn't trouble us as much as Delta did. That's another discussion. But we'll keep our fingers crossed. You're already facing the brunt of it. We are bracing for impact. So let's see what happens. So thank you very much for joining us. I think a few messages. Avoid esophageal intubation, use a video laryngoscope. Check all intubations with capnography. Use, if your capnograph trace is flat, exclude esophageal intubations by whatever means, which may be in a video laryngoscopy or a fiber optic intubation or reauscultation, ultrasound. And maybe you might have to change the tube or do something to confirm that problem. And human factors play a big role. Work in teams, collaborate, have a flat hierarchy, and hopefully we'll be able to avert all these avoidable mishaps that once in a while occur, but make our lives and patients' lives miserable. Yeah.
So, stay humble. Stay humble.
Okay, great. Thank you.
Lovely to see you. I hope your meeting's been good.
Hope meeting's going well, and hope we can meet sometime.
I look forward to seeing you in person. Nice to see you all. Bye-bye.
Thank you.
Thank you, Dr.